Hello, good evening, students. Yesterday we have discussed about lung cancer. Today we will be discussing about tuberculosis and acid-base baths. Very important topics. Good evening, students. I want everybody to join as soon as possible. Good evening, Yash, Avatar. Good evening, Sanskriti. Good evening, everybody. Hope all of you had your cup of tea in the evening. Yesterday we have discussed regarding lung cancer. Today the topics that we are going to discuss will be a very important disease. I also consider it as a national disease of our country, that is tuberculosis. And next, the most complex but interesting part, acid-base balance. Okay. Yash Agarwal, does CPAP follow principle of positive pressure ventilation? See, it is very simple logic. See, non-invasive ventilation, okay, it is of two types. We have CPAP and BiPAP. So BiPAP means it will give the two pressures. During inspiration, the pressure will be bit high. During expiration, the pressure will be bit less. CPAP, both during inspiration and expiration, there will be a constant pressure. So CPAP, it provides constant pressure during both inspiration and expiration. BiPAP, relatively higher pressure. So this is an advanced model. BiPAP is a bit advanced than CPAP. So depending upon the patient's respiratory effort, so it will sense the respiratory effort, and during inspiration there will be higher pressure. During inspiration, lower pressure during expiration. Okay, so this is something near physiological. So this, even we also during inspiration, it is an active process, we need more energy. Expiration is a passive process, so less effort required. So in the same way, BiPAP also, it is following the physiology of your body. So in NIV there will be CPAP, there will be BiPAP. CPAP generally we are using for obstructive sleep apnea. So CPAP generally we use for obstructive sleep apnea, whereas BiPAP usually for hypercapnic respiratory failure. So whenever there is type 2 respiratory failure, we have discussed, we have to give NIV. In that, preferred is BiPAP. For obstructive sleep apnea, generally patient will not be having any respiratory failure, so in the CPAP is preferred. So Yash Agarwal, CPAP is a type of non-invasive ventilation. Again, in an invasive mechanical ventilation, there are so many modes: pressure control mode, pressure support mode, volume control mode. See, IMV is a general term. Under that, there are so many modes. NIV is also a general term. In that, there are two important modes. One is CPAP, other is BiPAP. I hope you have understood this. Okay, shall we start? Yash Agarwal. Okay. Now coming to the next disease. So because of this disease, there are about 5 lakh deaths per year, 1400 deaths per day, and 1 death every minute, especially in our country. So what is that disease? Just like Thanos, it is tuberculosis. It can wipe out societies, tuberculosis. So previously they were considering tuberculosis as a great killer of human population. So this is king of all infections. So TB, king of all infections. Now we are having COVID. So before that, TB is king of all infections. But COVID, as years progress, or I mean as months progress, its virulence is decreasing. But tuberculosis, since last 3000 years, it is just progressively increasing, especially in our country. Coming to presumptive TB. Presumptive TB. So what is presumptive TB? So presumptive TB means a patient with any one of the following. Any one of the following features. So you found a patient with any one of the following features in the country. Fever more than 2 weeks, cough more than 2 weeks, hemoptysis, significant weight loss, radiological abnormality on chest X-ray, radiological abnormality on chest X-ray suggestive of TB. So in our country, if you find a patient with any one of the following features: fever more than 2 weeks, cough more than 2 weeks, presence of hemoptysis, significant weight loss, or radiological abnormality on chest X-ray suggestive of TB. So if any one of the following is present, he is presumed to have TB and he has to be evaluated further. And this term is called as presumptive TB. So very important. So what is the definition of presumptive TB? Any one of the following features: fever, cough, hemoptysis, significant weight loss, radiological abnormality on chest X-ray suggestive of TB. Now you are having a patient whom you are presuming to have TB. How will you proceed further will be the new algorithm for TB diagnosis. So recently there are a lot of changes in TB algorithm, and actually they have made the algorithm very complicated. So let me try to simplify it for you at your level. Now we have a patient who is presumed to have TB. So what you should know regarding the patient is this patient belonging to general population? So without any comorbidities or without any other issues, immunocompromised, he is suspected to have TB, or he is belonging to a special group. So when do you call a patient is belonging to special group? Whenever there is a HIV patient with respiratory symptoms. So symptomatic means this patient is having respiratory symptoms suggestive of TB, such as cough or some cough, hemoptysis, or fever, weight loss. So symptomatic means symptoms suggestive of tuberculosis. And symptomatic extrapulmonary TB. All these days patient was having lymph node TB. He was never having cough, but now he has developed cough. Pediatric patients. So any symptomatic pediatric patient who is having prolonged fever, cough, and contacts of pulmonary TB. So contacts of pulmonary TB who develop symptoms suggestive of TB. Diabetic patients with malignancy, malnourished patients, and patients on immunosuppressants. Even these patients, if they develop symptoms suggestive of TB, they have to be kept in this special group. So why I have divided it into two groups is because the next step will be different in both groups. Now if the patient is a routine individual who has developed fever, cough, and hemoptysis, he has come to your clinic, how will you evaluate further? So what I am going to do is, I am going to collect his sputum and I will send it for smear examination. Sputum smear examination. Sputum smear examination. So I go for staining, sputum smear examination, and simultaneously I also advise a chest X-ray. Here the initial investigations will be smear examination and chest X-ray. And according to new guidelines, how many sputum samples you should be giving? So 2 sputum samples. You should ask the patient to collect 2 sputum samples. After some times, you are going to compile the results like this. In the first scenario, patient's smear may be positive for TB bacilli. If at all patient's smear is positive, irrespective of the chest X-ray, it may or may not show tuberculosis. Irrespective of chest X-ray, if smear is positive, that is sufficient. So this patient is labeled as microbiologically confirmed case. So Sanskriti, again common sense. You are examining, see, for TB diagnosis, most important is smear examination, sputum examination. So how will cough be dry in TB? Because since ages, the national program is concentrating on sputum examination in TB. Because TB is producing productive cough, we are examining sputum. Then how come you think it is a dry cough? Because TB directly goes into alveoli, there will be secretions there. So dry is very rare in tuberculosis. Usually it will be productive cough. TB will be having big cavities. Cavities will be pulled with secretions and TB bacilli. Okay, cough is generally productive in tuberculosis. So microbiologically conformed. So we call it as microbiologically conformed case. So microbiologically conformed case. According to new guidelines, next you should perform NAT, nucleic acid amplification test, and you should plan or start treatment accordingly. You should start treatment accordingly. Microbiologically conformed case. Perform NAT and start treatment accordingly. Now in the second scenario, if at all patient's smear is negative but chest X-ray is strongly suggestive of TB. Smear is negative, chest X-ray is strongly suggestive of TB. According to the new guidelines, the next investigation will be NAT, nucleic acid amplification test. If the patient is belonging to this special group, the next investigation immediately will be NAT. So here the diagnostic algorithm is short because these are high risk group. I don't want to waste time. I directly go for NAT. So what is meant by NAT? NAT is a molecular method for identifying tuberculosis. It is nucleic acid amplification test. Nucleic acid amplification test. Previously in our country, there was only one NAT called as CB NAT. Here CB means cartridge based. CB means cartridge based nucleic acid amplification test. Whereas now we have Indian method called as TrueNAT. True is the name of the lab that has designed this device. We have Indian technique called as TrueNAT. Now what is the identification of nucleic acid amplification test? It will not only detect TB, it will also give information about rifampicin, whether this patient's TB bacilli are sensitive to rifampicin or resistant to rifampicin. Whether this patient's TB bacilli are sensitive to rifampicin or resistant to rifampicin. So try to understand this simple concept. Presumptive TB belonging to general population, smear examination, chest X-ray. Smear positive if chest X-ray, irrespective of chest X-ray, we consider it as microbiologically confirmed case. We perform NAT and start treatment accordingly. Smear negative, chest X-ray positive, we go for NAT. In special group, directly we go for NAT. So what is NAT? Nucleic acid amplification test. So we have CB NAT and also TrueNAT. The benefit is both will detect TB and also rifampicin sensitivity. Now if you observe here, now in tuberculosis, most important investigation has become NAT. In majority of these scenarios, we are performing NAT. In majority of these scenarios, we are performing NAT. Now once we have done NAT, depending upon the results, the algorithm will proceed further. Now this patient, you have performed a nucleic acid amplification test and you have identified tuberculosis in this patient. Now how to proceed further? So it might be either rifampicin sensitive or it might be rifampicin resistant. How to proceed further? Now, if rifampicin resistance is detected, what should be done? If rifampicin resistance is not detected, what will be done? See, this algorithm is very complicated. In the National Tuberculosis Program booklet, it is very difficult to understand. I have tried to simplify for you. So you have performed an act. So there was TB bacilli. So this TB bacilli, either it can be resistant or it can be sensitive. So either there is rifampicin resistance detected or rifampicin resistance not detected. Now suppose if rifampicin resistance is not detected, so what you should do next, you can start drug sensitive regimen and you should send for first line LPA. So DS regimen means drug sensitive regimen. So that is the first line regimen that you know. So drug sensitive regimen. So DS regimen means drug sensitive TB regimen. Drug sensitive TB regimen. So you must be knowing drug sensitive TB regimen. So it contains first line drugs HRZE. So we are going to start these drugs. How we are going to put them in a regimen, when I discuss treatment regimen, I will tell you. And you should send for first line LPA. Now you know that rifampicin resistance is not there. But you should also be sure that the other drugs such as isoniazid, ethambutol, pyrazinamide are also working well. But generally we go for knowing isoniazid resistant. Whether it is isoniazid resistant, yes or no. So this is first line. So we go for first line LPA. LPA means line probe assay. This is also a molecular method to diagnose TB and also drug resistance. So nucleic acid amplification test will only tell about status of rifampicin. Now suppose I want to know status of isoniazid, whether the TB bacilli is resistant or sensitive to isoniazid. I should go for line probe assay. So in line probe assay, you can select group of drugs. So if you want, you can go with first line LPA, first line drugs, and also second line drugs such as fluoroquinolones, aminoglycosides. So for that also resistance, you can measure with second line LPA. LPA is also a molecular assay which not only detects TB bacilli but also drug resistance. So it can detect drug resistance of not only rifampicin, isoniazid, fluoroquinolones, aminoglycosides, so many drugs. Now I am going to start the first line drug sensitive regimen and I am going to send for first line LPA to see whether the TB bacilli is resistant to isoniazid, yes or no. Now by that you will find H resistance is not detected. So once H resistance is not detected, now you can be happy because there is no rifampicin resistance, there is no isoniazid resistance. So this patient TB bacilli, you can easily control, you can easily treat it with the primary regimen, that is HRZE. So what you should do, so you should continue the first line treatment. So this is the first line treatment. So if they ask you what is first line treatment, HRZE. On the other hand, H resistance is detected. Now this H is not working. Now we have found out in this patient there is isoniazid resistance. So instead of isoniazid, you can remove that isoniazid and you should start levofloxacin. So what you need to do is you should start H resistant treatment. So what is H resistant treatment? You are going to remove isoniazid, you are going to replace it with levofloxacin. So levofloxacin plus rifampicin plus pyrazinamide plus ethambutol. So you are going to change the regimen and you should send for second line LPA. Now you are worried, you have started levofloxacin. You don't know whether previously patient is resistant to levofloxacin. You send for second line LPA. So LPA again for drug resistance. In second line LPA, they check whether TB bacilli is resistant to second line drugs such as fluoroquinolones. And also you should send for culture. So LC means liquid culture. So liquid culture will be more accurate for knowing the drug sensitivity. But the problem with liquid culture is it will take time for the results to happen. So it will take 2 or 3 weeks for liquid culture reports to eventually reach you. So you do second line LPA and you send it for liquid culture drug sensitivity testing also. So liquid culture drug sensitivity testing, even though it is accurate, but it is a time taking procedure. Then if at all you find anything positive in this, if at all patient is having levofloxacin resistance also, you are going to modify the regimen. If any additional resistance, you can modify the regimen. So see here, you have done nucleic acid amplification test. So on one side of the flowchart, if rifampicin resistance is not detected, how to proceed further. On other side of the flowchart, if rifampicin resistance is detected, how to proceed further. If rifampicin resistance is not detected, you can start the routine regimen and you should send for first line LPA. So in first line LPA, you will know whether patient is isoniazid resistant, yes or no. If there is no isoniazid resistance, you can completely relax and you can continue the first line treatment. If at all there is isoniazid resistance detected, if there is isoniazid resistance detected, you have to remove isoniazid from the regimen and you have to replace it with levofloxacin. And you should now send for second line LPA. See whether levofloxacin is working or not, and also you can send for liquid culture DST. Liquid culture DST is accurate in knowing the drug sensitivity pattern, but it is time taking. And depending on the results, if there is any additional resistance, you can modify the regimen. Now coming to the next slide. Now rifampicin resistance is detected. Here you should be very, very careful because rifampicin is the most potent first line ATT. So it is a very, very potent ATT. If TB bacilli has become resistant to rifampicin, it means it can become resistant to many drugs. So you should be very, very careful in this patient. So if rifampicin resistance is detected, you should immediately send, you should see whether this TB bacilli is also resistant to isoniazid, it is resistant to fluoroquinolones, aminoglycosides, and for accurate drug sensitivity testing, you should send for liquid culture DST. So you should send for all the investigations immediately because rifampicin is a potent drug. If TB bacilli is resistant to rifampicin, it means it can be resistant to other drugs also because it has overcome rifampicin itself, a strong drug. So it can overcome other drugs. So you have to send for first line, second line LPA and also liquid culture DST, and you should plan for treatment Now it may take some time for these results to be revealed. So meanwhile, you have to start treatment for rifampicin resistant TB or MDR TB. See, MDR TB means resistance to both isoniazid and rifampicin. Now because rifampicin is most potent drug, if patient is just resistant to rifampicin, we give the treatment same as MDR TB. Because if patient is resistant to rifampicin, eventually at some point of time he can also become resistant to isoniazid. So point to remember, so the treatment for rifampicin resistant TB and also multi-drug resistant TB will be the same. Now you have found out this patient to be rifampicin resistant, you are sending for investigations and you are starting the treatment. So first you should see whether this patient is fit for shorter MDR regimen. So there is a new regimen for MDR TB, that is shorter MDR regimen. So there are some exclusion criteria or contraindications. So if any contraindication or exclusion criteria is present, you cannot give shorter regimen, you should go for longer regimen. So there are some contraindications such as disseminated TB, CNS TB and pregnancy. So there are few contraindications that I will discuss later on. So if there are contraindications, don't start shorter regimen, go for longer regimen. So that is the concept that you should know. So there are contraindications. So plus means, so there is presence of contraindications. So what you should do, you should go for longer MDR TB regimen. If contraindications or exclusion criteria for MDR TB is present, shorter regimen is present, you should go for longer MDR TB regimen. If there are no contraindications, so if there are no contraindications or no exclusion criteria, you can go for the shorter MDR TB regimen. See, shorter MDR TB regimen, the duration is only 9 to 11 months, whereas longer MDR TB regimen is about 18 to 20 months. So what is the shorter regimen? What is this longer regimen? When we discuss treatment regimens, I will tell everything in detail. So till then, what you should know, whenever you find rifampicin resistance, be careful. You should send for all investigations. So first line LPA, second line LPA, you should see is he resistant to other ATT also, and you should plan treatment. So meanwhile, the results will come in 2 or 3 days. The LPA generally takes 2 to 3 days. So till then, you can start the patient on a basic regimen. See whether the patient is having any exclusion criteria for shorter MDR TB regimen. If there are exclusion criteria, directly go for longer MDR TB regimen. If there are no exclusion criteria, you can directly go for shorter MDR TB regimen. Meanwhile, you might get results from LPA and liquid culture, and depending on those results, if there is any additional resistance, you can modify the regimen. So if there is any additional resistance, you can modify the regimen. So this is the basic algorithm that you have to follow after doing nucleic acid amplification test. So as of now, in majority of the TB patients, we have to do NAT. And after doing NAT, if patient is rifampicin resistant, if he is resistant, you have to follow this path. If patient is rifampicin sensitive, that is rifampicin resistance not detected, you have to follow this path. So there are 2 paths. If rifampicin sensitive, what is the path? If rifampicin resistance, this is the path. So very, very important. Okay. So this is a very, very complex algorithm. So I tried to simplify for your level, for your exam. Now let us see various NATs available and few new updates. So the new updates, all TB cases, you should inform the government. So previously, whenever a patient with tuberculosis used to come to my clinic, private clinic, I used to start treatment. I never used to inform government because at that time there was no rule. But now, any TB patient reaching your clinic, you should inform the government that you are having a TB patient and you are treating him. And for all notified TB patients, you should provide drug sensitivity testing for at least rifampicin. So for at least rifampicin, what is the test? NAT. So you have to perform for all notified TB patients upfront NAT. You have to perform for all notified TB patients upfront NAT. So to provide universal DST, so this is a new update. So for all notified patients, you should see whether the TB bacilli is sensitive or resistant to rifampicin with upfront NAT. Now we are having 2 types of NATs in our country. So one is American made, US made, Videshi, CB NAT. The trade name is GeneXpert. So CB NAT and GeneXpert means the same. CB NAT or GeneXpert. So this is Videshi, American made. Whereas make in India, we have Desi handheld micro PCR device, India made. So what is that India made device? TrueNAT. So let it be CBNAT or TrueNAT, depending upon availability. You can perform the test with any one of the following. Now let us see some basic differences between CBNAT and TrueNAT. Now most of you must be knowing what is meant by a desktop computer and what is meant by laptop. See, what is the difference between desktop and laptop? See, laptop is portable. You can carry it wherever you want. And laptop usually has battery backup. You don't want any continuous power supply. So this is TrueNAT. See, TrueNAT, if you observe, this is a very small mission. So it is a handheld mission and it is a battery backup mission. So no need 24 hours current supply for maintenance of this mission. So you can easily use this mission in primary health centers and various villages. Whereas CBNAT is a very big mission. It is just like a desktop. It is not portable. It is stationary and it requires 24 hours of electrical supply. So this is the important difference between CBNAT and TrueNAT. See, the method of testing is the same, but the made up is different. So CBNAT, it is foreign made, it is stationary and it requires 24-hour power supply. Whereas TrueNAT, Indian made and it is portable device and it can work on battery. So no need of 24-hour power supply. So let it be CBNAT or TrueNAT, depending upon the availability. In all notified patients, you should perform that test, nucleic acid amplification test. And coming to the next important update. Yes, all these days we were calling the National Tuberculosis Program as RNTCP, Revised National TB Control Program. But down the lane, the results were not that satisfactory. What to do next? What to do next? Change the name. So now RNTCP has been changed to NTEP. It is just like Thanos becoming Tanish. So what is NTEP? National Tuberculosis Elimination Program. National Tuberculosis Elimination Program. So as of now, in our country, the national program for TB is no longer called as RNTCP. What is the new name? It is NTEP. What is NTEP? It is a National TB Elimination Program. It is a National TB Elimination Program. All the previous textbooks, the national program was called as RNTCP, Revised National TB Control Program. So now the name has been changed to National TB Elimination Program. National TB Elimination Program. Now let us see what is this concept of primary TB, secondary TB in your body. What is primary TB? What is secondary TB? Primary TB means first time infection with TB bacilli. First time infection with TB bacilli. Now consider this is the lung. For the first time, this patient is inhaling TB bacilli. So whenever somebody inhale TB bacilli for the first time, by virtue of gravity, where will majority of TB bacilli go? Mid and lower jaws. Most common site of deposition will be mid and lower zones. Most common site of deposition will be mid and lower zones. And this area of initial infection, it is called as Ghon's focus. So this area of initial infection, this area of initial infection is called as Gons focus. Now mostly this primary TB will happen in patients with good immunity. So whenever TB bacilli are coming into my body, so where is the immunity against TB bacilli generated from? What is the source of immunity? It is the lymphoid tissue. So there will be hilar lymph node enlargement. So to fight against this, there will be immunity generated and there will be hilar lymph node enlargement. Now this combination, Gons focus with hilar lymph node enlargement, this is called as Gons complex. So the parenchymal lesion individually is called as Gons focus, whereas with the hilar lymph node enlargement, it is called as Gons complex. You must be knowing Gons focus is also called as primary focus. Gons complex is also called as primary complex. So both are synonyms. We can either call it as Gons focus or primary focus, Gons complex or primary complex. I told you this primary TB happens in patients with good immunity. Because there is good immunity in this body, majority of the TB bacilli will be destroyed ultimately. Because TB bacilli are destroyed, even if the patient coughs out, the TB bacilli will not be coming out. So this patient will be less infective to others. So this patient is less infective form. Here body's immunity will take care of this TB. So in majority there will be spontaneous resolution or spontaneous healing. Body's immunity will take care of this TB. And very rare complications. Only in few there can be some complications. So I'll show you what can be the rare complications of primary TB in the next coming slides. Now coming to secondary TB. So secondary TB generally happens either because of reactivation or reinfection. It happens because of reactivation or reinfection. And most important prerequisite is decreased immunity. Because of some reason there will be slightly decreased immunity in this patient. So what is happening? So whenever the immunity is decreased in the body, so these TB bacilli will reach the apex and will start actively growing. So why will TB bacilli actively grow in the apex? Because these are areas of high oxygen tension and high ventilation perfusion ratio. So whenever there is decreased immunity, TB bacilli actively grow in apex. Actively growing. They can grow in other areas, but when compared to other areas, here they will be actively growing in apex. So because of their active growth, there will be areas of destruction. Around that areas of destruction, your immune cells can form a wall. So this area of destruction with the wall, what is this phenomena called as cavity? So there will be a cavity formation. There will be a cavity formation. And these cavities are generally pooled with TB bacilli. And this cavity can have communication to a bronchus. Bronchus will have communication to the trachea. So from the trachea, if the patient coughs out, these TB bacilli will coming into the atmosphere. So whenever patient coughs, from the cavity, TB bacilli will go into the bronchus, bronchus to the trachea, trachea to the atmosphere. So because of this patient will be highly infective form. So this patient will be highly infective form. And this is actually active disease. And this is the active disease. And if you don't treat properly, there will be frequent complications. Secondary TB is actually the active TB, and if you don't treat it properly, there will be frequent complications that we see in our clinical practice. Let us see what are those frequent complications associated with secondary TB. So there is a cavity. So this cavity can erode a blood vessel. So cavity can erode a blood vessel. So there can be cavity can erode a blood vessel, surrounding blood vessels. See, there will be so many blood vessels in your lung. So as the cavity extends, it can erode a blood vessel. So whenever blood vessel is eroded, there can be hemoptysis. And this cavity can sometimes rupture into the pleural space. Now cavity is an area filled with air. If only air goes into pleural space, patient will develop pneumothorax. If all that TB bacilli and necrotic material go into pleural space, there can be formation of pus in the pleural space. So pus in pleural space is called as empyema. So if only the air reaches the pleural space, there will be pneumothorax. If all this TB bacilli and necrotic material goes into the pleural space, there can be empyema. So the reason is rupture of cavity into pleural space. So this is another complication. And TB bacilli can directly damage the bronchi and result in bronchiectasis. So TB bacilli can directly damage the bronchi and result in bronchiectasis. And these areas ultimately can heal by fibrosis. So these areas will heal by fibrosis, and there can be extensive fibrosis later on. So all the TB involved areas, if you don't treat properly, so there will be severe damage to the lung, and all these severely damaged areas ultimately will be replaced by fibrotic areas. Now whenever lung is having majority of fibrotic areas, the gas exchange capacity decreases. So that result in hypoxemia. Now hypoxemia in long run can cause pulmonary hypertension, and your right ventricle after few months it will give up, resulting in right ventricular dysfunction called as cor pulmonale. These are some complications of secondary TB. There can be hemoptysis, pneumothorax, empyema, bronchiectasis, fibrosis, hypoxemia, pulmonary hypertension, cor pulmonale. Whenever you are seeing or suspecting primary TB, where do you find lesions? Mid and lower zones. You should look for this Gons focus, Gons complex. Whenever you are thinking about secondary TB, in majority it will be apex, and what you should be looking for, you should be looking for cavity. Out of these two, which is generally dangerous? Secondary TB. What might be the complications? Hemoptysis, pneumothorax, empyema, bronchiectasis, fibrosis, hypoxemia, pulmonary hypertension, and cor pulmonale. Now I'll show you some images so that you will understand this TB forms bit easily. Now first set of image. So this was an individual in whom TB bacilli are coming into the lung for the first time. So where will they deposit? Mid and lower zones. And how is immunity generated? From the hilar lymph node. Now what is this? So there is parenchymal focus called as Gons or primary focus, and hilar lymph node enlargement. So these two put together, it is called as Gons complex. So just 1 minute, students. Yeah, so some disturbance because of some construction work going around. I just requested them so to postpone their work. Okay, this is primary tuberculosis, Gons focus, hilar lymph node enlargement, both put together is Gons complex. Point to remember here is primary TB in majority will resolve by itself, and most probably there will be very rare complications. So nothing to worry regarding this primary tuberculosis. Now what are those very rare complications? So first important complication is, see, this lymph node can enlarge and compress a bronchus. So whenever the lymph node is enlarging and compressing a bronchus, so there can be enlarged lymph nodes can compress bronchus. So we have discussed previously. So if this is the lung and there is a big lymph node. So the size of the lymph node is very big. It has become very big. So it can compress this bronchus. So generally, which bronchus is compressed? Right middle lobe bronchus. So that results in right middle lobe collapse plus bronchiectasis. So what is this entity called as? It is called as Brock's syndrome. So the first complication is enlarged lymph nodes may compress the bronchus, resulting in right middle lobe collapse and bronchiectasis. And some TB bacilli can spill into the pleural space, resulting in pleural effusion. And in few, pleural effusion can be seen. So TB bacilli spilling into the pleura, resulting in pleural effusion. So the pleural tissue, so they will reach the pleural tissue, can cause some inflammatory response, resulting in pleural effusion. And next important thing, these TB bacilli in few patients who are very immunocompromised, first infection itself can cause dissemination throughout the lungs. So in absence of sufficient immune response, there can be dissemination. So usually in primary TB, what will happen? Body's immune response will take care of the TB. So when the patient is very immunocompromised, now what will happen? These TB bacilli will spread throughout the lungs. So this phenomena is called as dissemination, and it will become a primary progressive tuberculosis. So generally primary TB will not progress, it will resolve. Now if the patient's immunity is very less, so first infection itself can progress, resulting in primary progressive tuberculosis. So these are the three important complications. The lymph nodes can enlarge, resulting in Brock's syndrome. Pleural effusion can be seen. There can be a primary progressive tuberculosis because of absence of immune response in the body. So these are generally very rare complications of primary TB. Now whenever there is less immunity, TB bacilli reach the apex. So when they are infecting for the second time, so TB bacilli will reach the apex. Slightly less immunity, they will reach the apex and actively grow. And in that area, you will find areas of destruction called as cavities. So what are these? This is reactivation or secondary TB, also called as post-primary TB. Post-primary TB. So post-primary TB, secondary TB or post-primary TB. Secondary TB also called as post-primary TB. Now let us see some X-rays for understanding. What do you see in this X-ray? There is right hilar lymph node enlargement. Right hilar lymph node enlargement. So this side also there is right hilar lymph node enlargement. So this is primary TB. I told you in primary TB there will be spontaneous healing. So this is the parenchymal focus, which is healed and ultimately calcified. So this is calcified Gons focus, and all those lymph nodes can also eventually be calcified, healed and calcified. So primary TB in majority there will be spontaneous healing, nothing to worry. Now what do you see in this chest X-ray? Bilateral upper zone areas of infiltrations with cavities. So these are all tiny cavities here, and you can see a large cavity here. So these are upper zone areas of destruction. So all these are cavities. So where do you find such type of disease? Upper zone predominant and cavitary disease. So what is this type of TB? Is it primary TB or secondary TB? Is it primary TB or secondary TB? So this is secondary TB. Secondary TB is also called as post-primary TB. Secondary TB is also called as post-primary TB. Secondary TB is also called as post-primary TB. Now, whenever we are discussing regarding primary TB, mostly the lesions will be mid and lower zones. You can see hilar lymph node enlargement. Secondary TB generally presenting with cavities, upper zone predominant. Coming to TB pleural effusion, let us see what is this entity. So this TB pleural effusion can be either primary or secondary form. It can happen in primary tuberculosis or secondary tuberculosis. This is usually due to hypersensitivity. This is due to hypersensitivity to TB bacilli. Hypersensitivity to TB bacilli in the pleural tissue. It means, consider this is the lung. Surrounding the lung there is pleura. Now these TB bacilli will reach the pleura. So these TB bacilli will reach the pleura. So they will be located in the pleural tissue. So because of this TB bacilli in the pleural tissue, there will be an hypersensitivity response. So that hypersensitivity response will be responsible for pleural effusion. So pleural effusion is generally due to hypersensitivity to TB bacilli in the pleural tissue. So the concept here is, where will majority of TB bacilli be present? Is it in the fluid or is it in the pleural tissue? Your answer should be pleural tissue. And this pleural effusion, the characteristics are, it is exudative pleural effusion. First point, it will be lymphocyte predominant. It is lymphocyte predominant. And markers, we have ADA, adenosine deaminase, more than 40 international units. Interferon gamma will be more than 140 picograms per ml. So this we have already discussed in the topic called as pleural effusion. Tubercular pleural effusion, exudative, lymphocyte predominant, ADA will be high, interferon gamma levels will be high. And interesting feature is pleural fluid. Pleural fluid shows acid fast bacilli in only 20 to 30% cases. So if you take the fluid and if you look in the microscope, the TB bacilli presence will be very less, because TB bacilli are generally not located in the fluid. So they are usually not located in the fluid. Where they are present? They are present in the pleural tissue. Then what will be the gold standard test for diagnosis? Gold standard test for diagnosis. So your answer should be a pleural biopsy. So you should take pleural biopsy and you should send it for culture for Mycobacterium tuberculosis. So in majority, diagnosis of pleural effusion is through pleural fluid analysis only. So if it is showing exudative, lymphocyte predominant, high ADA, high interferon gamma, it is sufficient for diagnosis. But in the exam, if they ask you which is 100% suggestive of tubercular pleural effusion, within the pleural tissue, you should be able to isolate TB bacilli. So you should take the tissue, and you should send it for culture for Mycobacterium tuberculosis. So if they ask you what is the gold standard test, you should try to identify TB bacilli in the pleural tissue, because pleural fluid, the amount of TB bacilli is very less. Gold standard test is pleural biopsy and subjecting it for culture for Mycobacterium tuberculosis. Next we have TB HIV. So it is just like Thanos getting the Infinity Stones. So very dangerous combination. So TB, I told you, it is king of all infections. So if TB is the king of all infection, its queen will be HIV. So this TB HIV is just like a king and queen combination, always double trouble. So this TB HIV is always double trouble in your body. Now I'll give you some clinical scenarios. Try to tell me what should be done next. Now you were sitting in your clinic. In the morning, there was a patient with cough, hemoptysis and weight loss. You have suspected him to have tuberculosis and you have sent him for few investigations. So generally, whenever I am sending for TB investigations such as sputum smear, chest x-ray, according to the recent guidelines, this patient should also get his HIV testing done. Now by afternoon, this patient is sputum positive for TB bacilli and he is also HIV positive. Now this fellow is having TB HIV co-infection. So he is having both together, TB HIV co-infection, both you have diagnosed at the same point of time. Now what treatment should be started first? Will you start ATT or ART is the question. Now patient is having both TB and HIV together. Both these diseases should be treated ultimately. But what will you treat first? Is it ATT or ART? So which will you give first in TB HIV co-infection, ATT or ART? Type your answer. So in TB HIV co-infection, what should be started first? Is it ATT or ART? Type the answer, students. Yes, ATT or ART. Your answer should be ATT, anti-tubercular therapy, ATT. So what is the reason behind this? So I'll try to explain this with a very simple example. Now consider this is equilibrium. Okay. Now this patient is having two diseases. So TB, let me explain in terms of increased bacillary load. HIV in terms of low CD4 count. So now this patient is having TB HIV co-infection. Now if at all I start ART first, for example, antiretroviral therapy. So whenever I start antiretroviral therapy, there will be decreased viral replication and your CD4 count will improve. So your CD4 count is improving. So whenever your CD4 count is improving, there is immunity reconstitution. Now what will this reconstituted immunity do? It will see this TB bacilli and give an inflammatory response. So this phenomena is called as immune reconstitution inflammatory syndrome. So because of this, patient will develop fever, lymphadenopathy. Now most important aspect in management of TB HIV is not just prescribing the treatment. You should make sure patient is routinely using the treatment without any side effects. Now if at all patient is getting few features such as fever, lymphadenopathy, early in the treatment phases, this patient will leave the treatment and run away from you. So there will be no proper usage of the drugs. So to avoid this, what I am going to do is I will give ATT first, followed by ART. Now if I give anti-tubercular therapy, what is the benefit? So again, this patient TB, high bacillary load, and HIV, low CD4 count. Now if I start ATT first, the TB bacilli load will come down. After 2 weeks to 2 months, if I start ART, even though the immunity is getting reconstituting, there are no sufficient TB bacilli to give that inflammatory response. Because that abnormal inflammatory response is not happening, so patient will tolerate the medications and he will continue the medications. So in TB HIV co-infection, if ART is started first, there is risk of iris. So what is this iris? Iris is nothing but immune reconstitution, inflammatory syndrome, immune reconstitution, inflammatory syndrome. To overcome this problem, what we do? We start ATT first and merge ART within 2 weeks to 2 months duration. So within 2 weeks to 2 months duration, we will merge ART. See, ultimately both should be given. So how they should be given? First ATT, later ART. Within 2 weeks to 2 months, you have to start it. Now another clinical scenario, there is already a patient with HIV. So there is already a patient with HIV, and now unfortunately he has developed tuberculosis. So already patient is on ART HIV, but after few months he has developed tuberculosis. Now how will you adjust the regimen of ATT? So there are few drugs in ART and one drug in ATT which has significant drug interaction. So what is that ATT which has significant drug interactions with ART? It is rifampicin. So when to give rifampicin, when to avoid rifampicin. So if this patient with HIV, if patient is on TLE regimen. What is this TLE regimen? Tenofovir, lamivudine, efavirenz. So this is the first line ART regimen in majority of the areas. So tenofovir, lamivudine, efavirenz, this is the routine ART regimen. If patient is on this regimen, I can give rifampicin. Rifampicin can be given. Rifampicin can be given. Whereas if patient is on nevirapine, protease inhibitor based regimen. Nevirapine protease inhibitor based regimen. Nevirapine protease inhibitor based regimen. We have to give rifabutin. Rifabutin given instead of rifampicin. Rifabutin given instead of rifampicin. So in simple words, if patient is on the routine ART, rifampicin can be given routinely. If patient is on nevirapine protease inhibitor based regimen, what you should give? You should give rifabutin, because rifampicin, so this drug called as rifampicin, has significant side effects or drug interactions with nevirapine protease inhibitors. So what are the protease inhibitors that you know? Yes, protease inhibitors, lopinavir, ritonavir, indinavir, all those. If in the question they mention TLE regimen, rifampicin can be given. If it is nevirapine protease inhibitor based regimen, rifabutin should be given instead of rifampicin. Coming to another recent update, all asymptomatic HIV patients. So now there was an HIV patient, he is not having fever, cough, weight loss, hemoptysis, anything. And those in whom active TB is ruled out. And there was another patient with 1 or 2 symptoms, and you have done all the tests. So you have done CBNAT, you have done chest X-ray. In all that, there is nothing suggestive of TB. What will you do next? So all these patients should be offered isoniazid preventive therapy for 6 months. So very important, all HIV patients. So once HIV diagnosis is done, if they are asymptomatic or if they are having, suppose they are having symptoms, you evaluate for tuberculosis, and if there is no active TB in all these patients, isoniazid preventive therapy for 6 months should be given. If at all you have identified tuberculosis, according to the algorithm, you are going to treat him. So very important. So if they mention in the question, there was a HIV patient, he was not having any symptoms, he was referred to the pulmonologist clinic, what will you do next according to new guidelines? So if patient is not at all having any symptoms, next will be isoniazid preventive therapy. So I am going to prescribe isoniazid for 6 months and send him. If at all he is having some symptoms, I am going to do nucleic acid amplification test. If there is active TB, I am going to start the complete regimen. If there is no tuberculosis, I am going to start isoniazid preventive therapy. Isoniazid preventive therapy. So this is a new update. All asymptomatic HIV patients and those in whom active TB is ruled out, they should be offered isoniazid preventive therapy for 6 months. Now coming to the presentation of TB in HIV. So there is a slight difference when compared to normal individuals. So before understanding this, try to understand this concept. Now suppose in a healthy individual, there is 100% immunity. So consider a healthy individual is having 100% immunity. Okay, let his immunity score be 100% for example. So when his immunity is 100%, if some TB bacilli reaches his body, your body's immunity will take care of that TB bacilli and it will make sure there is no active disease. Now suppose this patient's immunity has decreased to 60%. So when his immunity has decreased to 60%, so there will be active TB developing in his body, and this TB will be like this. So generally secondary TB like pattern. So you can see upper zone cavities. So generally the concept behind cavity is, so there will be destruction due to TB bacilli. Around that your remaining immune cells, so they are less. So they try to form a wall so that that infection is not going to the next area. So there will be some cavitations. Now if the patient is severely immunocompromised, so patient is only having 20% immunity. Now when he is severely immunocompromised, what will happen is, now this fellow immunity even cannot form cavity walls. So it cannot wall off the infection. So because of this, these TB bacilli can be disseminated everywhere into the body. So they can go into the other lung, they can go into the mediastinum, they can cause some lymphadenopathy like that. So try to understand, tuberculosis disease is nothing but interplay between the TB bacilli and your immune system. If your immune system is very good, TB will not happen. If there is slight immunity impairment, there can be secondary tuberculosis, usually upper zone disease. If there is significant immunity impairment, there will be a disseminated disease. So same thing will happen in HIV. So in HIV patients whose CMI is only partially compromised, So it means his immunity is decreased, but not to that significantly low level. So pulmonary TB presents in a typical manner. So typical manner is upper zone cavities. Upper zone cavitary TB. Upper zone cavitary TB. So when cell mediated immunity is only partially compromised. So still there is some immunity remaining. So which is not sufficient to kill the TB bacilli, but it is sufficient to form a wall around the TB bacilli. It is sufficient to form a wall around TB bacilli. It is sufficient to form cavities around TB bacilli. Now in late stages, when CD4 count is very less, a primary TB like pattern, that too primary progressive TB, so it will be everywhere. So with interstitial infiltrates, little or no cavitation and dissemination into mediastinal lymph nodes. So more of disseminated TB. So more of disseminated TB. So point to be noted. So when the immunity is good, you will see classical upper zone TB. You will see classical upper zone TB. So when immunity is not good, so you can see TB bacilli spread everywhere. So they can from the first route of entry. So they enter into the lung, mid and lower zones. From there itself they can spread. So they can spread throughout the lungs. So they can spread into the mediastinal lymph nodes. So they can cause pleural effusions. They can cause mediastinal lymph node enlargement. And generally cavities are not seen. See, for cavity to form, your immune system should be active at least of some capacity. So your immune system is not at all active. So there will be no cavities. There will be lymph node enlargement. So TB bacilli will disseminate into the mediastinum. So TB bacilli can cause pleural effusion. It can cause interstitial infiltrates. It can go into the interstitium and it can spread throughout the body also sometimes. So in late stages, a primary TB like pattern. So you can see the lesions in the mid and lower zones with interstitial infiltrates, little or no cavitation. There will be pleural effusion and intrathoracic lymphadenopathy is seen. If you see some pictures, you can understand this better. Now, if you notice, there was a HIV patient with CD4 count more than 200 mmQ. So he is having some partial compromise. So what do you see here? You notice upper zone cavities. So you notice upper zone cavities. You notice upper zone cavities. Okay. You notice upper zone cavities. Now there is a HIV patient. There is a HIV patient with a very low CD4 count. So here what has happened? So the TB bacilli have just entered here. They have started to form disease in the mid and lower zones. So and they are also extending here. So they can extend into the mediastinum also. So in patient with low CD4 count, you don't find these typical cavitations. So you find some interstitial infiltrates. So they can extend into the mediastinal lymph node enlargement. So later there can be pleural effusions and disseminated TB. So CD4 count or immunity, it is only partially compromised. You will see upper zone disease as other patient. If the immunity is severely compromised, you can see initially the mid and lower zones. So then interstitial infiltrates, lymphadenopathy, pleural effusion, all sorts of dissemination can be seen. So this is the difference between HIV patient tuberculosis presentation. If the immunity is only partially compromised, upper zone disease. If it is severely compromised, disease can itself start in mid and lower zones and it can disseminate to various parts of the body also. Now coming to miliary TB. So this is a special type of TB characterized by tiny nodules in the lung. So that's why it was called as miliary TB. This miliary TB can be classified into two forms. We have classical miliary TB and cryptic miliary TB. Coming to classical miliary TB, so this can occur either as primary or secondary form. This can occur either as primary or secondary form. So this is due to hematogenous spread of TB bacilli. This is due to hematogenous spread of TB bacilli. Now, how is this happening? Now, consider this is one alveolus, this is another alveolus. So, in between alveoli, there will be interstitium and there can be blood vessels like this. In this entity, the TB bacilli first reach the alveoli. Because of some unknown reason, these TB bacilli, everything will go into the interstitium. From the interstitium, they can go into a blood vessel. From the blood vessel, they will be disseminated throughout the body. Now, if you do sputum examination for acid-fast bacilli, so will it be positive or negative? It will be negative. So you don't find TB bacilli in the sputum because TB bacilli are not residing in the alveoli. They have migrated into the interstitium and they will proliferate, and few bacilli can go into the blood vessels. From the blood vessels, they can be disseminated to various parts of the body. And one of the characteristic feature is, if at all you do an eye examination in fully blown out disease, eye examination reveals choroidal tubercles. In your eye, there is a layer called as choroid. So choroid is a vascular layer. Now, presence of choroidal tubercles in the eye examination indicates that these TB bacilli have disseminated to various parts of the body. What do you identify on the chest X-ray? There is a classical feature: bilateral, symmetric, diffuse, 1 to 2 mm millet-shaped shadowing. 1 to 2 mm millet-shaped shadowing. So 1 to 2 mm millet-shaped shadowing. The size is very important. 1 to 2 mm millet-shaped shadowing. Now coming to cryptic miliary TB. What is meant by cryptic? Cryptic means something hidden. Now why this is called as cryptic miliary TB? Let us discuss with help of a clinical scenario. So these patients generally will be elderly. So they will be elderly and they can have some chronic symptoms. Chronic symptoms such as fever, weight loss, there can be anemia. Whenever an elderly patient with chronic symptoms reaches to my clinic, what will be my differential diagnosis? So one differential diagnosis in our country will be chronic infection such as tuberculosis or some malignancy. Now first I need to rule out a common disease called as tuberculosis. So what I will be doing? I will be doing his sputum examination. So his sputum will be negative for acid-fast bacilli and his chest X-ray done will also be normal. Whenever sputum is negative, chest X-ray is normal. Now I feel that I have ruled out tuberculosis in this patient because sputum is negative, chest X-ray is normal, and I will be evaluating for some other disease. But suddenly one day what happens is patient collapses. That will result in his death. So patient might collapse and it can result in his death. So now I have been evaluating this patient, but there was death happening. I wanted to know what caused the death in this patient. So what I will do, an autopsy was performed. So this autopsy reveals meningeal tubercles. Autopsy reveals meningeal tubercles, suggestive of disseminated miliary TB. Now what is this? This patient's sputum was negative, chest X-ray was normal, but the autopsy picture was showing meningeal tubercles suggestive of disseminated miliary TB. So what must have happened in this patient? So in this patient also there must have been miliary TB, but the nodules were very small that were not visible on chest X-ray. To be visible on chest X-ray, the size of the nodule should be at least 1 to 2 mm. So in this disease, the size of the nodules might be very, very tiny. Because of that, they were hidden on chest X-ray. This is also miliary TB, but not visible on chest X-ray, hidden on chest X-ray. That's why it is called as cryptic miliary TB. This is also miliary TB, but hidden on chest X-ray. Fortunately, this is a very, 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 very rare type. So generally not seen in your clinical practice, just for academic purpose. This is also miliary TB, but hidden on chest X-ray. Now you can get a doubt. See, patient's sputum is negative, chest X-ray is normal. If at all you want to identify this type of tuberculosis before mortality happens, what you should do next? You can get a CT chest done. So in CT chest, the nodules might be visible. So if at all the nodular pattern, so the miliary pattern, if it is visible directly on chest X-ray, it is called as classical miliary tuberculosis. Okay, we can go for classical miliary TB. If at all the nodules are visible only on CT chest, so nodules are not visible on chest X-ray, so we can call this as cryptic miliary TB. So Pranab Mohanty, that's what I am telling. If you are unable to see on chest X-ray, go for a CT scan. So if nodules are seen on CT scan but not visible on chest X-ray, that phenomena is called as cryptic miliary TB. So that is the thing that you should do. So you are suspecting it to be some miliary TB, but you are unable to find nodules on the chest X-ray. You get a CT scan then. If it is found on CT scan, then you can call it as cryptic miliary TB. Now what do you notice in this chest X-ray? Try to observe here, top to bottom, side to side. Okay, you can see tiny millet shaped shadowing. So you can see small dots, symmetrical distribution, top to bottom, side to side. This is the classical miliary pattern. Same thing you can also appreciate on the chest X-ray. So bilateral symmetric 1 to 2 mm millet shaped shadowing. So can you see this? Whitish nodules. So whitish tiny nodules. Okay. So now in the question, if chest X-ray is normal and CT chest is suggestive, that entity should be called as cryptic miliary TB. If the miliary pattern is clearly visible on chest X-ray itself, that pattern should be called as classical miliary TB. So in this question, you can see the miliary pattern. I mean, in this image, you can see the miliary pattern both on chest X-ray and CT scan. So this is a classical miliary pattern. Okay. Now coming to the treatment of tuberculosis. Treatment of tuberculosis, we can classify it into treatment of drug sensitive TB and drug resistant TB. Now coming to drug sensitive TB, according to the new guidelines, let it be a new case or previously treated case. A new case or previously treated case. The regimen and duration will be the same. It is 2HRZE plus 4HRE. It is for duration is 6 months. According to new guidelines, if it is a drug sensitive TB, okay, a new case or either let it be a previously treated case. The regimen is the regimen is 2HRZE plus 4HRE. See, Ash Agarwal, in granular pattern also, it can be similar to miliary pattern. Okay, it can be similar to miliary pattern, but you need the clinical history. So if you are having signs of infection, chronic infection, so fever, some cough, shortness of breath, weight loss, so you can go more with tuberculosis. Okay. Again, very important aspect is radiology. Depending upon the radiology, you cannot come to a diagnosis. Just giving an X-ray, I cannot say this patient is having this disease and I cannot start the treatment. If it is so, radiologists, they themselves will start treatment. So radiologists will give you an opinion, will give you a pattern. Depending upon the patient scenario, you should correlate with that and you should diagnose him. So if there is a granular pattern also, if it is such, you take a CT scan, if you find well-defined nodules, okay. So in this you find well-defined nodules, and if there is some clinical history such as fever, some cough, weight loss, all this you can think it as miliary tuberculosis and you can start treatment. Only based on radiology, you cannot diagnose majority of the conditions. You need some clinical history also. So in bilateral granular pattern, the size can be variable. It can be variable and it will not be that symmetric as seen in this phenomena. A new case, previously treated case. The regimen is 2HRZE plus 4HRE. 2HRZE plus 4HRE. Then coming to drug resistant TB. So we'll see first isoniazid resistant TB. It means the TB bacilli is resistant to only isoniazid. Isoniazid resistant TB. So the regimen will be 6 months of levofloxacin. So I have removed isoniazid plus rifampicin plus pyrazinamide plus ethambutol. You must be knowing H stands for isoniazid, R stands for rifampicin, Z stands for pyrazinamide and E stands for ethambutol. If it is isoniazid resistant TB, I am removing isoniazid and I am adding levofloxacin and I am continuing the treatment for 6 months. Then we have MDR TB, multi-drug resistant TB, multi-drug resistant TB, MDR TB. MDR TB means resistance to both. Resistance to both H and R. And as I told you previously, let it be MDR TB or rifampicin resistant TB. The regimen will be the same because rifampicin is first line ATT, most potent ATT. If the TB bacilli has become resistant to rifampicin, eventually there can be some resistance to isoniazid. So let it be MDR-TB or rifampicin resistant TB, the duration and regimen will be the same. So what is the regimen? So the regimen is for 18 to 20 months. 18 to 20 months. And what are the drugs? We give bedaquiline. Bedaquiline. Clofazimine. Clofazimine. Cycloserine. Cycloserine. Levofloxacin, linezolid. And among these drugs, this bedaquiline is stopped after initial 6 months. See, the total duration of the regimen is 18 to 20 months. In that, bedaquiline is only given for initial 6 months. So bedaquiline stopped after initial 6 months. Next we have XDR-TB. What is XDR-TB? XDR-TB means extensively drug resistant TB. The definition is it is an MDR-TB. It is an MDR-TB that becomes resistant to. It is an MDR-TB that becomes resistant to 1-fluoroquinolone, 1-fluoroquinolone and 1 second-line aminoglycoside and 1 second-line aminoglycoside. So if the TB bacilli is already MDR, multi-drug resistant, and it is becoming resistant to 1-fluoroquinolone and 1 second-line aminoglycoside. This phenomena is called as XDR-TB, extensively drug resistant TB. Now what is the regimen? So the regimen here will be 20 months. So the drugs should be given for 20 months. And what are the drugs? The combination will be the same. Bedaquiline plus clofazimine plus cycloserine plus levofloxacin plus linezolid. And point to be remembered here, again, this bedaquiline, it is stopped after initial 6 months. It is stopped after initial 6 months. And I have discussed there might be resistance to 1-fluoroquinolone. If that 1-fluoroquinolone is levofloxacin, for example, if levoflox can't be given, you can replace it with moxifloxacin. Moxifloxacin given. If levofloxacin can't be given, you can replace this with moxifloxacin. Here, the regimen for isoniazid resistant TB, it is for 6 months. Whereas, multi-drug resistance, it is 18 to 20 months. XDR TB, 20 months. So, these are the new regimens. 2019-2020 guidelines. So we have discussed here in this single slide what is the regimen for isoniazid resistant TB. What is the regimen for MDR TB? Same applies to rifampicin resistant TB. What is the regimen for XDR TB? What is the regimen for XDR TB? Apart from this, for MDR TB and rifampicin resistant TB. So for this group, not for XDR TB, there is a shorter regimen. See, the longer regimen is about 18 to 20 months. So they have brought a shorter regimen for MDR TB, rifampicin resistant TB given by the World Health Organization. So in that shorter regimen, the duration of treatment is only 9 to 11 months. You should also know what are the drugs used in that shorter regimen and in whom it should be avoided. I have discussed earlier, there is some exclusion criteria for shorter MDR-TB regimen. So we will also discuss what is that. Write down WHO shorter MDR-TB regimen. Yes, Agarwal, every drug has side effects. So bedaquiline can have QT prolongation, cardiac toxicity. Okay. So that's why if at all patient is having some pre-existing heart disease, while giving bedaquiline, you should be very, very cautious. So again, then don't ask, sir, why you are giving bedaquiline if there are some side effects. So it's like risk-benefit ratio. If you don't give bedaquiline, patient is not going to improve. If you give bedaquiline, majority will improve, minority will develop side effects. So medicine is always risk-benefit ratio. So you're going to see what is the percentage of risk when compared to benefit. If the benefit percentage is more, so to save the life of the patient, you should eventually do that. So Pranab Mohanty, if there is deranged LFT, you have to stop the hepatotoxic drugs. Isoniazid is hepatotoxic, rifampicin is hepatotoxic, pyrazinamide is hepatotoxic. You can continue ethambutol. After few days, again you check LFT. After checking LFT, if the LFT has come back to normal, so you are going to restart the drugs one by one. So instead of dumping all the drugs, you can start isoniazid slowly from low dose, then rifampicin, then pyrazinamide. So what is the benefit of knowing XDR-TB if the treatment is same as MDR-TB? So to know the prevalence of resistance, how bad the TB bacilli is there. Okay, see, in moderate to severe cases, sometimes the treatment will be the same. What is the benefit of knowing is it moderate or severe? So to know the prevalence of resistance, so how bad the TB bacilli is there. And if at all, if there is some fluoroquinolone resistance, okay, see here, that's what we have discussed. If there is fluoroquinolone resistance, so you are going to remove levofloxacin, you give moxifloxacin. So Pranab Mohanty, it will again, see, TB treatment, that stoppage temporarily will hamper, but if you keep on giving that hepatotoxic drug, patient is going to die of liver failure before tuberculosis. So are you willing to kill the patient with liver failure, or wait till his liver improves and go for and gradually treat him? If it is a severe disease, you can start streptomycin, you can give ethambutol, you can give levofloxacin. These will not have any effect on the liver generally. Okay, so you can stop for a while. If patient is comfortable, you stop for a while and let his hepatotoxicity come down or let his liver function improve. Then you can give, you can gradually reintroduce the drugs. So if at all he is severely ill, so then you can give the combination of ethambutol, you can use streptomycin, you can give a fluoroquinolone such as levofloxacin. So because these are also having anti-tubercular activity, and these will not have any effect on the liver. This will not have any effect on the liver. Okay. So Himani Gupta, the answer to your question is, what is the benefit of knowing XDR? Because if there is fluoroquinolone resistance, you are not giving levofloxacin, you are replacing it with moxifloxacin, definitely you are getting an advantage there. Okay. And if moxifloxacin is also resistant, you go for next drug, you can give delaminate. So Yash Agarwal, if aminoglycoside resistance in XDR-TB is there, what is the substitute? See, previously we were giving aminoglycosides in MDR-TB. Now there is no substitute at all. So that mission is going to measure both fluoroquinolone and aminoglycoside resistance. See, later on, if at all these drugs are not working, you think of giving aminoglycoside in XDR-TB. you cannot give because it is already resistant. Okay. So there are other drugs. You are having dilaminide, you are having para-amino salicylic acid. Okay. Now let us see WHO shorter regimen for MDR-TB. WHO shorter regimen for MDR-TB. The duration is 9 to 11 months. For initial 4 to 6 months, we are going to give high dose isoniazid, kanamycin, ethionamide, moxifloxacin, clofazimine, ethambutol, pyrazinamide. So these are the drugs given for first 4 to 6 months. Along with that, the next 5 months. The next 5 months. So we will give moxifloxacin, ethambutol, clofazimine, pyrazinamide. Okay. The total duration is 9 to 11 months. Initially for 4 to 6 months, this is the combination. Later 5 months, this will be the combination. Now you should get a valid doubt. It is MDR-TB, but I am giving isoniazid. But it is not a routine dose isoniazid, it is high dose isoniazid. Recent studies have shown that whenever you are giving high dose isoniazid in combination with other drugs, the drug resistant bacilli were also getting destroyed better. So when isoniazid is given at high doses, so there was good clearance of these TB bacilli. That's why it was included in the regimen. It was based on lot of studies. Now in whom this MDR shorter regimen should be avoided. So there are some exclusion criteria. So in pregnancy, generally we avoid because we are giving some aminoglycosides here, we avoid it. So in disseminated TB, CNS TB, still there are no sufficient study to prove its efficacy. Whenever there is disseminated TB, we generally need prolonged duration of treatment. So 9 to 11 months may not be sufficient for this patient. So we usually go with the traditional oral longer regimen. We go for the longer regimen. And if at all already patient is having resistance, intolerance to any second line drug in the regimen. So if the patient is already he has used fluoroquinolones for pneumonia, or already he is using some aminoglycoside for some other ailment. So in this patient you cannot give because ultimately because of chronic use of those drugs, his body might have become resistant. So if you give these drugs, the patient will not improve. And extrapulmonary TB in HIV. Recent studies have shown that in extrapulmonary TB in HIV, still the evidence is not sufficient to start the shorter regimen. So here also we go for longer regimen. In pregnancy, disseminated TB, CNS TB, if there is documented resistance, intolerance or previous exposure of any second line drug in regimen, actually it happens in many parts of our country. So those practicing mixopathy, will start giving aminoglycosides and fluoroquinolones for very simple pneumonias also. So that's why we have to avoid the use of fluoroquinolones for routine pneumonias. Extrapulmonary TB in HIV. Pregnancy, disseminated TB, CNS TB, resistance or intolerance, previous exposure of any second line drug in regimen, extrapulmonary TB in HIV, extrapulmonary TB in HIV. In these conditions, generally we avoid shorter regimen. Now for tuberculosis, there are two important new drugs exclusively designed for tuberculosis. See, there are other drugs such as kanamycin, ethionamide, moxifloxacin, clofazimine. See, all these were not exclusively designed for tuberculosis. So these were having some additional activity against tuberculosis. So they were designed for some other diseases, but incidentally they found to be having some activity against tuberculosis. Per se for tuberculosis, two new drugs have been designed. So one is bedaquiline, other is delaminide. So new in the sense, bedaquiline was approved in 2012, delaminide was approved in 2014. So after rifampicin, pyrazinamide, ethambutol, isoniazid, so the next approved drugs were bedaquiline and delaminide. So this bedaquiline belongs to diaryl quinolone group. So it belongs to diaryl quinolone group. Mechanism of action is ATP synthase inhibition. Mechanism of action is ATP synthase inhibition. Side effect of this drug is QT prolongation, cardiac toxicity, QT prolongation. It is QT prolongation, and it is to be used only in drug-resistant TB. Only when you identify drug-resistant TB. So especially from MDR TB onwards, you should use. You should not use it for routine drug-sensitive TB. So the dose generally started at a dose of 400 mg, later tapered to 200 mg. So later decreased to 200 mg. So later decreased to 200 mg. So it is once daily dosing. It is once daily dosing. Then coming to delaminide. This is belonging to nitroimidazole group. It belongs to nitroimidazole group. Mechanism of action is mycolic acid synthesis inhibition. Mycolic acid synthesis inhibition. So here also side effect is QT prolongation. Here also side effect is QT prolongation. This is also used only in drug-resistant TB. So the dose is generally 100 mg BD. So the dose of delaminide is 100 mg BD. The dose of delaminide is 100 mg BD. Apart from this, very recently, there was another drug approved for management of tuberculosis. It is predominate. So predominate is younger brother of delaminide. It belongs to the nitroimidazole group. The mechanism of action is same. The mechanism of action is the same. Yes, Pranab Mohanty, initially for 2 weeks 400 mg, then it is decreased to 200 mg for the next 22 weeks. Yes. So 24 weeks in the sense it is equivalent to roughly 6 months. So it is the same. 400 mg OD for initial 2 weeks. So later next 22 weeks we can give 200 mg. Or else if there is some adverse event initially only, we can decrease the bedaquiline dose. So it all depends upon patient's clinical response. And initially we will give it daily later we will convert it into alternate days. Okay. So pretominate, it belongs to nitroimidazole group. It is also acting through mycolic acid synthesis inhibition, and this pretominate has a specific side effect. It has a specific side effect. What is that specific side effect? So P for pretominate, P for peripheral neuropathy. So P for pretominate, P for peripheral neuropathy. So based on this, there is a new regimen for XDR-TB. So it is called as B-PAL regimen. So it is not yet approved for routine use in our country. So there was one study done with this combination. So B-PAL means B for bedaquiline, PA for pretominate, L for linezolid. So this is announced on 4th August 2020. So bedaquiline, pretominate, linezolid. So they have identified that this combination was helpful in XDR-TB, especially highly drug-resistant tuberculosis, XDR-TB. So it has been shown in few studies that it is helpful, but not yet approved for routine use in our country. So which is approved for routine use? Bedaquiline is approved for routine use. Delaminide is approved for routine use. So this is a recent update. So there is a B-PAL regimen for XDR-TB. So B is bedaquiline, PA is pretominate, and L stands for linezolid. L stands for linezolid. L stands for linezolid. So they are trying to bring this 3-drug regimen for XDR-TB. So studies have shown some positive impact, but to tell exactly that this is going to work, it has to be tried on larger population. So let us see, mostly by the end of next year, this might be coming into our country for routine use. So 3 important drugs that you should know. One is bedaquiline, delaminide, pretominate. And pretominate, why did it become famous? Because it was part of B-PAL regimen. So bedaquiline, pretominate, linezolid for treatment of XDR-TB. Okay. So this completes the recent updates regarding tuberculosis. Now coming to the next topic. Whenever I say acid-base balance, arterial blood gas analysis, this will be expression of majority of students. The simplest reason is it is mathematics. We all hate mathematics, that's why we have come into MBBS. Now mathematics, just like your old girlfriend, is back with vengeance in the form of arterial blood gas analysis, acid-base balance. One good thing about mathematics is majority will be formula based. Okay. See, if I write 3 plus 2 is equal to 5, even if I write it as 2 plus 3, 1 plus 4, 4 plus 1, the answer will be the same. So in ABG analysis also, there will be few set of formula. If you know how to apply them, where to apply them, your life becomes very, very easy. Now let us start ABG analysis with normal values. So normal values of pH 7.35 to 7.45. PaCO2 35 to 40 mmHg. Bicarbonate 22 to 26 milliequivalents. PaO2 70 to 100 mmHg. These are some set of reference value. Each and every lab will have different reference values, but this is the range. For ABG analysis, these three are very important: pH, PaCO2, bicarbonate. In this present lecture, for calculation purpose, any pH less than 7.35, I will consider this as acidosis. Any pH more than 7.45, we will take it as alkalosis. Simple chemistry principles: if pH is less, it is acidosis. If pH is more, it is alkalosis. For calculation convenience, we will take normal CO2 as 40, the upper limit, and normal bicarbonate as 26. I am taking the upper limit of the values. How are these pH, PaCO2 and bicarbonate related? Write down: relationship between pH, PaCO2 and bicarbonate. This is given by the famous equation called as Henderson-Hasselbalch equation. Henderson-Hasselbalch equation. Just like in mathematics, we have a plus b whole square is equal to a square plus b square plus 2ab. This Henderson-Hasselbalch equation is also such basic equation for ABG analysis. So everything in ABG analysis, acid-base balance, ultimately follows this Henderson-Hasselbalch equation. According to this equation, pH is equal to 6.1 plus log of bicarbonate by PaCO2 into 0.03. I am not concerned with all these values. I wanted to only know relationship between pH, bicarbonate and CO2. If I write it separately, pH will be proportional to bicarbonate by PaCO2. Now, why this relation is very important, we will know it in few minutes. Now, suppose in my body bicarbonate is increasing. So if bicarbonate increases, pH and bicarbonate are directly related. So what will happen to pH? pH will increase. In chemistry, any substance when added to my body, if it is increasing the pH, what is that substance equivalent to? Base. So in my body, bicarbonate is base. It is equivalent to base, because if bicarbonate is increasing, pH will also increase, because both are directly related. In the same way, because of some disease, if CO2 is increasing in my body, what should automatically happen to pH? pH will reduce, because pH and CO2 are inversely related. If CO2 increases, pH will decrease. Any decrease in pH is called as acidosis. Again, the same concept. When any substance added to my body is causing decrease in pH, what is that substance called as? Acid. According to Henderson-Hasselbalch equation, base in my body is bicarbonate. See, everything is very simple. So it is just simple mathematics. Base in my body is bicarbonate, whereas acid in my body will be CO2. So acid like substance in my body will be CO2. Now if at all the change in pH is primarily due to change in bicarbonate, so this parameter is metabolic. So the process it causes is called as metabolic process. If change in pH is predominantly happening due to change in CO2, this is a respiratory parameter. So the process that it results is called as a respiratory process. So bicarbonate is responsible for metabolic process. If change in pH is predominantly due to change in CO2, this phenomena is called as a respiratory process. Now try to understand this with some clinical examples. Now I am sitting in this room. I have suddenly stopped my respiration. Okay, I have suddenly stopped my respiration. What will be the acid base abnormality in my body? I have stopped my respiration. Yes, tell me. Whenever I stop my respiration, CO2 in my body increases. If CO2 increases, pH will decrease. Decrease in pH is called as acidosis. This is due to CO2. So what this phenomena should be called as respiratory acidosis. Now in the same way, I am running for 2 kilometers and I am hyperventilating like this. Now what will be the acid base disorder in my body? So whenever somebody hyperventilates, there will be carbon dioxide washout. So from my body, carbon dioxide is losing. So whenever CO2 decreases, pH should increase because both are inversely related. So increase in pH is called as alkalosis, and it is due to CO2. What is this phenomena called as? Respiratory alkalosis. So in short, CO2 retention, it is respiratory acidosis. CO2 washout will be respiratory alkalosis. So very important, students, when you find carbon dioxide is getting retained in the body, it should be called as respiratory acidosis. So there is nothing complicated here. It is just common sense and common things, not rocket science. CO2 washout will be called as respiratory alkalosis. Okay. Then another example. Now there was a patient with diabetic ketoacidosis. So because of this accumulation of keto acids, his bicarbonate level has decreased in the body. So whenever bicarbonate decreases, what will happen to pH? pH will also decrease. So decrease in pH is acidosis. This is happening to bicarbonate decline. So what it should be labeled as? Metabolic acidosis. Now in a patient with metabolic acidosis due to diabetic ketoacidosis, what will be the special pattern of breathing? He will be having very rapid breathing. What is that called as? Kussmaul's breathing. Now why will a patient with metabolic acidosis show that very rapid breathing? What is the concept behind this? See, already in patient's body there is metabolic acidosis. So there is increased acid. To fight against this metabolic acidosis, my respiratory system will try to throw out acid-like substance called as CO2 out. for this metabolic acidosis, my body is trying to compensate it with respiratory alkalosis by sending the carbon dioxide out, So in general, whenever there is respiratory problem, so respiratory acid-base disorder, my body will try to compensate with metabolic phenomena. If primary problem is in metabolic process, my body will fight with respiratory process. So in simple words, if the problem in your body is increase in acid, what your body will do? It will increase the base. If the primary problem is increase in base, that is alkalosis, how will your body fight against it? By generating increase in acid, acidosis. So this will be just like action reaction. So you must be knowing Newton's third law, action reaction. So if action is acidosis, reaction by your body will be alkalosis. If action is alkalosis, reaction will be acidosis. In the same way, if action is through respiratory phenomena, reaction will be through metabolic phenomena. If reaction is through metabolic phenomena, reaction will be through respiratory phenomena. So this is something normally happening in all of us. It is a defense mechanism. So if there is respiratory acidosis, so increase in CO2, respiratory acidosis, how will your body fight against it? Increasing the base, bicarbonate. So the compensatory phenomena will be metabolic alkalosis. Now if the primary problem is increase in base, metabolic alkalosis, how will your body fight against it? By increasing the acid, that is respiratory acidosis. So for acidosis, it will be alkalosis. For respiratory, it will be metabolic, and this will be vice versa. So such acid-base disorders are called as simple acid-base disorders. It means there will be a primary process to fight against that, to bring the pH to near normal. Your body will generate an adequate compensatory response. So write down simple acid-base disorders. Simple acid-base disorders means there will be a primary process happening in your body because of some disease. To fight against that, to bring the pH to near normal, your body will generate an adequate compensatory response. Your body will try to generate an adequate compensatory response. First, we will understand how to identify the primary process. Then I will also tell you how to calculate the compensatory response. Write down what are all the primary process that you come across, individual primary disorders. We have respiratory acidosis. So this slide is very, very important. If you understand this slide, 50% of ABG will be done in this slide. Metabolic acidosis, metabolic alkalosis. Now in all this, we are going to compare pH, PaCO2, bicarbonate. Same parameters. pH, PaCO2, bicarbonate. Now let us start with respiratory acidosis. Okay. Kindly follow me. It is actually very easy. But if you get confused, it becomes very complex. So this is a very, very simple phenomena. Follow the laws of mathematics. It will be very, very easy. Okay. Now you only tell me respiratory acidosis. To call it as acidosis, what should happen to pH? pH should decrease. To call it as acidosis, pH should decrease. Now to call it as a primary respiratory phenomena, predominant change should happen in which parameter? CO2 or bicarbonate? See, which is responsible for respiratory disorder? Common sense, it is CO2. So what happens in respiratory acidosis? CO2 will be elevated. Now for respiratory acidosis, what will be the compensation? Metabolic alkalosis. So bicarbonate will also increase. In the same way, respiratory alkalosis. To call it as alkalosis, pH should be increased. To call it as a primary respiratory disorder, where the change should happen predominantly CO2. So what should happen in respiratory alkalosis? CO2 will be declined. For respiratory alkalosis, what is the compensatory response? Metabolic acidosis. Bicarbonate will decrease. Now coming to the metabolic phenomena, to call it as an acidosis, pH will be reduced. Again the same question. To call it as a primary metabolic disorder, where should the change predominantly happen? Bicarbonate. What should happen to bicarbonate in metabolic acidosis? Till now we have discussed what will happen in metabolic acidosis. Bicarbonate decreases. So whenever there is metabolic acidosis, for metabolic, compensation will be through respiratory. For acidosis, compensation will be through alkalosis. Respiratory alkalosis. CO2 will be declined eventually. Now coming to metabolic alkalosis. What should happen to pH in alkalosis? Increase. What should happen to in metabolic phenomena, where the change should primarily happen? Bicarbonate. In metabolic alkalosis, what should happen to bicarbonate? It should increase. For metabolic alkalosis, what is compensatory phenomena? For metabolic, it will be respiratory. For alkalosis, it will be acidosis. So CO2 will be elevated. So this is how primary acid-base disorders behave. To understand this better, there are three important rules. To understand this better, there are three important rules. Rule number 1. Let it be any disorder, respiratory or metabolic, acidosis or alkalosis, always the primary change compensation will be moving together. Always the primary change and compensation will be moving together. It means if primary change is increase in CO2, compensation will be increase in bicarbonate. If primary change is increase in bicarbonate, compensation will be increase in CO2, and it will be vice versa. So rule number 1, in simple acid-base disorder, always primary change and compensation, will move together. If you observe here, primary change, compensation, primary change, compensation. They are moving together. Now in primary respiratory disorder. So in a primary respiratory disorder. Now it is particularly respiratory disorder. Change in pH with respect to CO2 and bicarbonate. Change in pH with respect to CO2 and bicarbonate will be in opposite direction. Whereas in primary metabolic disorder, change in pH with respect to CO2 and bicarbonate. Change in pH with respect to CO2 and bicarbonate will be in same direction. Write down the rules. I will tell you the logic behind this. Rule number 2. In primary respiratory disorder, change in pH. WRT means with respect to change in CO2 and bicarbonate will be in opposite direction. Whereas in primary metabolic disorder, change in pH with respect to change in CO2 and bicarbonate will be in same direction. So see the direction of arrow marks, you will understand what I am telling. Now what is the logic behind this? Again, it is all based on Henderson-Hasselbalch equation. Now tell me, to call it as a primary respiratory disorder, the change in pH is predominantly happening to which parameter? It is due to CO2. Now how is pH and CO2 related? It is inversely related. If CO2 increases, pH will decrease. If CO2 decreases, pH will increase. The logic here is, in a primary respiratory disorder, change in pH is predominantly happening due to change in carbon dioxide. pH and CO2 are inversely related. So change in pH with respect to CO2 and bicarbonate will be in opposite direction, because here pH follows CO2 and pH and CO2 are inversely related. So change in pH with respect to CO2 and bicarbonate will be in opposite direction. In the same way, to call it as a primary metabolic disorder, the change in pH is predominantly happening due to which parameter? Bicarbonate. How is pH and bicarbonate related? Direct relation. If bicarbonate increase, pH increase. If bicarbonate decrease, pH will also decrease. So the logic here is, in a primary metabolic disorder, the change in pH is predominantly due to bicarbonate. pH and bicarbonate are directly related. So change in pH with respect to CO2 and bicarbonate in metabolic disorder will be in same direction, as pH is going to follow bicarbonate, and pH and bicarbonate are generally directly related. So have you understood? In respiratory disorder, because it is due to CO2 change, pH and CO2 are inversely related, so the change will be in opposite direction. If one decreases, other will increase. Whereas in metabolic disorder, change in pH is predominantly due to bicarbonate. pH and bicarbonate are directly related. So if one increase, other also should increase. So they are going to be in same direction. To remember this better, there is a famous mnemonic called as ROME, ROME. It means in primary respiratory disorder, the change will be in opposite direction. In primary metabolic disorder, the change will be in same direction. So respiratory, the change will be opposite. Metabolic, the change will be in same direction. The change will be in same direction. So this is the famous ROME mnemonic. Now if you do some questions, you will understand this better. So write down the list of questions. So we will solve it one by one so that you will understand this better. So first question. pH 7.32, CO2 60, bicarbonate 34. Even if you don't know any basics of ABG, just to draw arrow marks, you will know the answer. So arrow marks in the sense direction of pH. pH is decreased. See, normal pH is 7.35 to 7.45. It is decreased. CO2 normal value is 40. It has increased. Bicarbonate normal value is 26. Here it is 34. Now whenever they give you any ABG analysis, first see the pH. Is it acidosis or alkalosis? Decreased pH anywhere is acidosis. The next step is it metabolic or respiratory? Now if you see here, change in pH with respect to CO2 and bicarbonate, it is in opposite direction. So what should be the primary here? Respiratory. So it is respiratory acidosis. Next question. Draw arrow marks, you will get the answer. What has happened to pH? Elevated. CO2 reduced. Bicarbonate reduced. Any increase in pH anywhere is alkalosis. Now you only tell me, is it respiratory or metabolic alkalosis? Once again, change in pH. pH has increased. CO2 bicarbonate decreased. Change in pH with respect to parameters opposite. What should be the primary? Your answer should be respiratory. So this is respiratory alkalosis. Now you only do this question. I am not going to help you. Draw arrow marks. You will get the answer. Just to draw arrow marks, apply the ROME formula. It is done. Yes. pH decreased. CO2 decreased. Bicarbonate decreased. Now any decrease in pH anywhere should be called as acidosis. Now what is the primary process? Change in pH with respect to parameters is in same direction. So what should be the name? Metabolic. It should be metabolic. Then last question. Draw arrow marks, you will get the answer. pH increased. CO2 increased. Bicarbonate increased. What has happened to pH? Has increased. So it has to be called as alkalosis. Alkalosis. Now is it metabolic or respiratory? Change in pH with respect to parameters. It is in same direction. So what should be the name? Yes, metabolic. Metabolic. Once again, let us go through those three rules. Let it be any disorder. Always primary process and compensation. Always the primary change and the compensation will be moving together. Okay. And if it is a primary respiratory disorder, change in pH with respect to parameters will be in opposite direction. If it is a primary metabolic disorder, change in pH with respect to parameters will be in same direction. So with these three basic rules, you can solve about 50% of ABGs. Now, what was the definition of simple acid-base disorder? There will be a primary process. To that, there can be a compensatory response, adequate compensatory response. Now, how to calculate the adequate compensatory response? Calculation of compensation. So, first we will calculate compensation for respiratory acidosis. We have acute respiratory acidosis, chronic respiratory acidosis. Then we will calculate compensation for respiratory alkalosis. See, for each and every disorder, there is a specific formula. So they have done so many studies and they have derived these formulas. Okay. So you should apply that formula and see whether there is adequate compensation, yes or no. Now for acute respiratory acidosis, for every 10 mm Hg increase in CO2. This is an acute phenomena. Still your kidney is not used to this phenomena. So bicarbonate will only increase by 1 milliequivalent. Now in chronic respiratory acidosis, for every 10 mm Hg increase in CO2. Now this is a chronic phenomena. Now your kidney got used to this phenomena, so it will retain more bicarbonate. Bicarbonate increases by 4 milliequivalents. Now how to use this formula in questions? Now suppose there was a patient. Now first of all, how to tell whether it is an acute phenomena or chronic phenomena? So most important is the patient's clinical history. Now if at all patient comes to you with some foreign body aspiration, so is it acute phenomena or chronic phenomena? Acute phenomena. If he comes with some chronic neuromuscular disorder, it is generally a chronic phenomena. Now the formula says that in an acute disorder, so consider this is equilibrium. If CO2 increases by 10 mm Hg of CO2, CO2 increases by 10 mm Hg, bicarbonate should increase by 1 milliequivalent. Now for example, this is equilibrium. Now in this patient, CO2 has increased from normal value of 40, it has increased to 60. To call it as a compensatory phenomena, bicarbonate from normal value of 26, it should increase to how much? See, CO2 has increased from 40 to 60. It has increased by 20. So for 10 it is 1. For 20 it will be 2. So if bicarbonate increases from 26 to 28, it is considered as adequate compensatory response. Now another example. Now because of some chronic disorder, CO2 from normal value of 40, it has increased to 60 mm Hg. Now to call it as a compensatory response, bicarbonate from normal value of 26 should increase to how much? See, for 10 it is 4, for 20 it should be 8. CO2 has increased from 40 to 60. So bicarbonate should increase from 26 plus 8, 34. So if it reaches to 34, it is considered as adequate compensatory response. So this is how you should apply this formula. Now for acute respiratory alkalosis, the formulas are slightly different. For every 10 mm Hg decrease in CO2, bicarbonate decreases by 2 milliequivalent. for every chronic disorder, 10 mmHg decrease in CO2, bicarbonate decreases by 4 milliequivalents. Depending on the clinical scenario, you should apply these formulas. Whenever you are having a respiratory acidosis, depending on the patient's clinical scenario, if it is acute respiratory acidosis, apply this formula. If it is chronic, you have to use this formula. For respiratory alkalosis, depending upon acute or chronic, you can use these formulas. Now let us do a question, clinical question, so that you will understand this better. Write down, there was a patient with chronic neuromuscular disorder. There was a patient with chronic neuromuscular disorder. NMD means neuromuscular disorder. I have done an ABG. His pH was 7.32. His PaCO2 was 60 and his bicarbonate was 34. Now I want you to identify the primary disorder and I want you to calculate the compensatory response. How to identify? Just to draw arrow marks. pH reduced, CO2 increased, bicarbonate increased. Any decrease in pH anywhere, it should be called as acidosis. Change in pH with respect to parameters, it is in opposite direction. So what should be the primary? Respiratory. Now there is respiratory acidosis. Now is it acute respiratory acidosis or chronic respiratory acidosis? Patient is having a neuromuscular disorder. Generally it is a chronic respiratory acidosis. Now you should calculate compensation. Now how to calculate compensation? In this patient, CO2 has increased from normal value. So 40 is the normal value. It has increased to 60. It means it has increased by 20. To call it as an adequate compensatory response, bicarbonate from normal value of 26, it should increase to how much? For 10 it is 4. For 20 it will be 8. 26 plus 8, 34. If you see here, the given bicarbonate and expected bicarbonate are correlating. It means there is adequate compensatory response. So chronic respiratory acidosis with compensatory metabolic alkalosis. But I am very lazy to write this big name. So it can also be written as, is it acute or chronic phenomena? Chronic. Is it adequately compensated? Yes or no? Yes. Chronic compensated. Whenever you want to write one phenomena, you should always write the primary phenomena. Chronic compensatory respiratory acidosis. Either you can write it in detail, chronic respiratory acidosis with compensatory metabolic alkalosis, or in short, chronic compensated respiratory acidosis. Now here I have labeled it as a compensatory phenomena, a compensated respiratory acidosis, or there is adequate compensatory metabolic alkalosis. But if you observe, the pH is not yet normalized. It is still in the acidic range. So point to remember here is, these compensatory phenomena in your body are some temporary mechanisms. So to bring the pH to near normal. See, the function of compensatory phenomena is to bring the pH to near normal. Suppose if compensatory phenomena are not happening. So if there is an acidosis, so the pH will be so much decreased such that your body's metabolism will not happen and patient will die eventually. So your body compensatory mechanisms or temporary phenomena to bring the pH to near normal, so that you will have time to get this condition treated. So to correct the pH, the underlying condition should be treated adequately. So whenever there is a compensatory phenomena happening in your body, it will not normalize the pH generally. It will only bring the pH to near normal. It will bring it to the safety range, so that still your body's metabolism will be happening. So if that compensatory phenomena is not there, so the progression of pH, either it will become very low or very high, such that your body will not function properly. So the role of compensatory phenomena is to bring the pH to near normal, not to completely normalize the pH. So this is how you should calculate metabolic compensation whenever you identify a primary respiratory disorder. Now let us see, if there is a primary metabolic disorder, how to calculate respiratory compensation. So write down compensation for metabolic disorders. So compensation for metabolic disorders. We have metabolic acidosis, metabolic alkalosis. For metabolic acidosis, we use a famous formula called as Winter's formula. According to this formula, expected CO2 is equal to 1.5 into bicarbonate. So this is a formula. Plus 8 plus or minus 2. 1.5 into bicarbonate plus 8 plus or minus 2. Now let us try to do a question to understand this better. So there was pH 7.29, PaCO2 22, bicarbonate is 10. First tell me what is the primary disorder and later calculate the compensatory response. Very simple, draw arrow marks. pH reduced, CO2 reduced, bicarbonate is also reduced. Okay, so bicarbonate is also reduced. Any decrease in pH anywhere, acidosis. Change in pH with respect to parameters, it is in same direction. So what should be the name? Metabolic. Whenever there is primary metabolic acidosis, I should calculate respiratory compensation. Just substitute in this formula. Expected CO2 1.5 into bicarbonate. How much is the bicarbonate? 10. Plus 8 plus or minus 2. 1.5 into 10 is 15. 15 plus 8. 15 plus 8 plus or minus 2. It is 23 plus or minus 2. To call it as adequate compensation, CO2 should be in the range of 21 to 25. How much is given CO2? 22. How much is expected? It is correlating. So metabolic acidosis with compensatory respiratory alkalosis will be the answer. Metabolic acidosis with compensatory respiratory alkalosis will be the answer. Now for metabolic alkalosis, it is a simple formula. Expected CO2 is equal to bicarbonate plus 15. So in the question, if you identify primary metabolic disorder, you should calculate compensation with this Winter's formula. In the same way, in the question, if you identify primary metabolic alkalosis, you should calculate compensation with the help of this formula. So with the help of this formula. Now we have understood how to calculate compensation for each and every disorder. Respiratory acidosis, alkalosis, metabolic acidosis, alkalosis. Whatever we have learned up to now, let us put it into an algorithm form. Write down ABG algorithm. ABG algorithm. So whenever they give you any ABG analysis, most important is not those numbers. What is the clinical history of the patient that resulted in those numbers? Because ultimately I am not going to treat that acidosis or alkalosis. I am going to treat the disease that is responsible for acidosis or alkalosis. Say whenever there is some foreign body in the throat, patient is having some respiratory acidosis, I am not going to inject some base into his body. I am going to remove that foreign body, then only that respiratory acidosis will be corrected. So the primarily why I should know clinical history, because ultimately to correct this acid-base disorder, I should treat that disease responsible. After going through the clinical history, then look at the pH. By seeing the pH, you should be able to identify, are you dealing with acidosis or alkalosis? I think most of you can identify this. If pH is less, acidosis. If pH is more, alkalosis. Then next important will be, what is the primary disorder? Or what is the primary process responsible? And depending upon the direction of arrow marks, I think you will be able to identify, is it a respiratory primary process or a metabolic process? So here respiratory process means it can either be acidosis or alkalosis. Metabolic process means it can either be metabolic acidosis or alkalosis. After identifying the primary process, next will be calculation of compensation. If you have identified a primary respiratory disorder, what compensation you should calculate? Metabolic. If you have identified a primary metabolic disorder, you should calculate respiratory compensation. So for each and every disorder, there is a set of formula, and you should compare what is given bicarbonate, given value and expected value. So you know how to calculate the expected value. So in majority, the scenario will be like this. Given and expected will be correlating. So here also, given CO2 is correlating with expected CO2. So whenever given value and expected value is correlating, it means there is adequate compensatory response. What is the definition of simple acid-base disorder? There will be a primary process to that adequate compensatory response. So this phenomena can be labeled as simple acid-base disorders. Simple acid-base disorder. But in few instances, you can get a scenario like this. Given bicarbonate not correlating with expected bicarbonate. In the same way, here also. Given CO2 not correlating with expected CO2. When given and expected or correlating, it is a simple acid-base disorder. When given and expected or not correlating, it means inappropriate compensation. When they are correlating, it is adequate compensation. When they are not correlating, inappropriate compensation. Previously, they were using the terminologies such as decompensated, uncompensated, partial compensated. Now all these terms have been removed when there is some adequate clinical history. So we are putting this under a single heading called as mixed acid-base disorder. If it is correlating, it is simple acid-base disorder. If it is not correlating, it is mixed acid-base disorder. What is this mixed acid-base disorder? Once we discuss all the individual disorders, I will discuss in detail later on. Now after this, what is the next step? Next step will be calculation of anion gap in blood. Calculation of anion gap, also written as AG. So after calculating anion gap, if at all there is a high anion gap, if there is high anion gap, we should compare change in anion gap and change in bicarbonate. So this change in anion gap, in some books it is written as delta anion gap. Change in bicarbonate, it is written as delta bicarbonate. What is this delta anion gap? Delta bicarbonate. So or delta, what is anion gap concept? So we will discuss in the next slide. So till then, let us see whatever we have learned up to now. So whenever they give you any ABG analysis, go through the clinical history responsible, that could be responsible. And by seeing the pH, I think most of you can tell whether it is acidosis or alkalosis. Then what is the primary process? By seeing the direction of change. If it is in opposite direction, respiratory, same direction, metabolic. And by using the set of formula, you should calculate compensation. If it is correlating, given unexpected values, it is adequate compensation, simple acid-base disorder. Not correlating, inappropriate compensation, it is now classified as mixed acid-base disorder. And the last step will be calculation of anion gap in the blood. If there is high anion gap, you should also compare change in anion gap and change in bicarbonate. So we'll take a break for 15 minutes. You can ask me your doubts in the next 5 minutes. 15 minutes break. So Sanskriti, they are not having cough. How were they diagnosed as TB? So that's what the thing I'm asking. So here TB chest ward, on what basis they were diagnosed as TB? To call it as TB, there should be some sample. So what is a sample? You have to take sputum. If sputum patient is unable to produce, you should do bronchoalveolar lavage. If you are not doing it, how can you confirm the diagnosis of tuberculosis? Please tell me, Sanskriti, in your TB chest ward, without microbiological evidence, how will you tell that this microorganism is causing TB? So maybe they might be treating based on chest X-ray features. Right now, only treating on chest X-ray features is not indicated. You should try to get sample and you should try to get microbiological confirmation. See, generally metabolic processes will be acute in presentation only. Okay. See, any metabolic disorder you have to correct immediately. If there is severe metabolic acidosis, you have to treat. Metabolic alkalosis, you cannot wait. But in respiratory acidosis, if there is chronic respiratory acidosis such as COPD, so no need to bring down the CO2 immediately. So that's why in classification, respiratory processes generally have acute, chronic. So metabolic, usually when they happen, they are acute phenomena only. See, it depends upon, in few single bronchi can be involved, in some multiple bronchi can be involved. You take a CT scan, you will notice. It depends upon the area which there is obstruction. Again, Sanskriti Tiwari, very simple. If secretions are clogging in single bronchus, so that bronchus will undergo bronchiectasis. If multiple bronchus are undergoing obstruction, so they will undergo bronchiectasis. It is just like a patient has fallen down. Will single bone be broken? Multiple bones be broken? It all depends upon the amount of injury that he sustained. In the same way, there is an insult to the lung. If many bronchi are involved, the bronchiectasis can be seen in many areas. It is as simple as that. Welcome back, students. So we have discussed up to this point the algorithm. Next will be concept of anion gap in blood and metabolic acidosis. Concept of anion gap in blood and metabolic acidosis. In my body, there will be two compartments. Just 1 minute, let everybody join. Now we are going to discuss the concept of anion gap and metabolic acidosis. In my body, there will be two compartments, a positive compartment and a negative compartment. To maintain electroneutrality, see, still we did not discuss about ABG sampling. In ABG sampling, I'll tell you what is the preferred site of ABG. Okay, Pranab Mohanty. So generally we prefer radial artery. In your body there will be two compartments, a positive compartment and a negative compartment. So to maintain electroneutrality, total number of positives will try to be equal to total number of negatives. Whereas in positive compartment, what are the routinely measured ions bedside? We are having sodium, potassium. In negative compartment, the routinely measured ions bedside are chloride and bicarbonate. Always between the measured positives and measured negatives, there is a significant gap called as anion gap. So write down, anion gap is the difference between measured positives minus measured negatives. Anion gap is the difference between measured positives and measured negatives. So for example, let us take this equivalent to the negative compartment. So in this bottle, this is considered as measured part and this will be considered as unmeasured part. Now because of some disease, if measured part is decreasing, automatically unmeasured part increases. If unmeasured part increases, the measured part will decrease. So just like in this bottle, always the measured part and unmeasured part will adjust to maintain total volume of this compartment. So in each compartment, again you will have a measured part. It means which is routinely measured bedside, and other is unmeasured part. Now in measured positives, we have sodium and potassium. Now what is normal value of sodium? Normal value of sodium will be about 135 to 145. What is normal value of potassium? It is somewhere 3.5 to 4.5. When compared to sodium value, the value of potassium was very less. So recently, for calculation of anion gap, new formula, they stopped taking potassium because its value was less. New formula for anion gap is equal to Na plus minus chloride plus bicarbonate. If you calculate with this formula, normal anion gap will be 8 to 12 milli equivalents or 10 plus or minus 2. So this 10 is taken as the reference value. So if any exam, if they ask you to calculate anion gap, now you should use this new formula only. And normal anion gap, the range is 8 to 12 milli equivalents or 10 plus or minus 2. So 10 is taken as the reference value. So this is something happening in all of us. In all of our bodies, there is always a gap between measured positive and measured negative. So this phenomena is called as anion gap. Now how does this anion gap influence in metabolic acidosis? Let us see. Based on the anion gap, we can classify metabolic acidosis into high anion gap metabolic acidosis and other is normal anion gap metabolic acidosis. Let us see in detail. Again the same compartments, a positive compartment, a negative compartment. As we have discussed earlier, positive compartment is predominantly made up of sodium. Negative compartment is made up of chloride, bicarbonate, and always between these two there is a gap called as anion gap. Now for development of high anion gap metabolic acidosis, the initiating event will be addition of acid to body. There will be some addition of acid to body. Now consider an acid called as H2SO4. How will it ultimately divide? H plus HSO4 minus. An acid called as HNO3. How will it divide? H plus NO3 minus. Now how will lactic acid divide? H plus lactate. How will formic acid divide? H plus formate. How will salicylic acid divide? H plus salicylate. So any acid in the universe, ultimately it should divide into H plus and corresponding acid anion. It should divide into H plus. It should divide into H plus and corresponding acid anion. Now whenever H plus is increasing in my body, so whenever H plus is increasing in my body, so which is the most important buffer for H plus? Bicarbonate. So this bicarbonate will be used up. So this bicarbonate will be used up as a buffer. So because bicarbonate is being used up, what happens to the value of chloride and bicarbonate put together? It will decrease because bicarbonate is getting consumed. It is metabolic acidosis. Anion gap is increasing. It is high anion gap metabolic acidosis. And again simultaneously bicarbonate is getting consumed. This acid anion is also negatively charged. It starts accumulating in unmeasured compartment, resulting in persistence of high anion gap. So to understand this high anion gap metabolic acidosis, you should focus on three important phenomena after addition of acid. So whenever addition of acid is happening, the first important phenomena is consumption of bicarbonate. So consumption of bicarbonate. Consumption of bicarbonate will result in metabolic acidosis. Simultaneous addition of acid anion to the unmeasured compartment. Both put together will cause persistence of high anion gap. So three important phenomena that you should see. Consumption of bicarbonate resulting in metabolic acidosis. Addition of acid anion. These two put together will result in persistence of high anion gap. So there is metabolic acidosis. When compared to normal individual, the anion gap has increased. So it is called as high anion gap metabolic acidosis. To understand this better, I have made a video. So try to see in this video also those three phenomena. So what are the phenomena? Consumption of bicarbonate. simultaneous addition of acid anions to the unmeasured compartment, increase in anion gap. So this is something normal, sodium bicarbonate chloride, and you are having anion gap. Now to this body, acid is added. Acid divided into H plus acid anion. Now bicarbonate is getting consumed. Acid anion being added. What has happened to anion gap? It has increased. So once again, these three steps. Consumption of bicarbonate. Addition of acid anion. Increase in anion gap. So write down the mechanism. The mechanism. Rise in anion gap. Rise in anion gap is due to simultaneous decrease in bicarbonate and increase in acid anion. So what are these acid anions? They are nothing but they correspond to the unmeasured anions. So they will be added to the unmeasured anion component. So rise in anion gap. So if anion gap is increasing, it is due to simultaneous decrease in bicarbonate and increase in unmeasured anions. But if you see ABG analysis, you will only see the anion gap rise and decrease in bicarbonate. So you cannot notice these unmeasured anions because they are not measured routinely. So because of that, there is a relationship. For every 1 milli equivalent increase in anion gap. So if anion gap is increasing by 1 milli equivalent, what does it mean? Bicarbonate has decreased by 1 milli equivalent. So rise in anion gap is due to simultaneous fall in bicarbonate and increase in acid anions. But in ABG analysis, you are not going to measure the unmeasured anions. You will only see the rise in anion gap and decrease in bicarbonate. So what will be the relationship? For every 1 milli equivalent increase in anion gap, bicarbonate will decrease by 1 milli equivalent. Now what are the causes of high anion gap metabolic acidosis? It is due to addition of acid. So when will acid be added to your body? So there are 4 groups of high anion gap metabolic acidosis. First group, whenever a patient is taking some alcohol, you must be knowing alcohol will be ultimately converted into aldehyde to acid. If patient is taking methanol, it will get converted into formic acid, ethanol, acetic acid, ethylene glycol, oxalic acid. So first group is taking some toxins or drugs. Drugs such as, say, tell me one drug which is acid, salicylic acid. Second group, when will acids be produced more in your body? For example, ketoacidosis. Ketoacidosis, it can be either diabetic ketoacidosis, starvation ketoacidosis, or it can be due to alcoholic ketoacidosis. And next important acid, endogenous acid, is lactic acidosis. And finally, when will all the acids produced in your body not go out from your body? When your kidney is not functioning well. That is nothing but renal failure. So 4 important groups, either due to toxins or drugs, ketoacidosis, lactic acidosis, renal failure. Write down causes of high anion gap metabolic acidosis. Causes of high anion gap metabolic acidosis. So first group, toxins or drugs. Toxins such as methanol poisoning, Peraldehyde. Aldehyde will also get converted into acid. Ethylene glycol poisoning. Ethylene glycol, the commercial name is antifreeze. When somebody drinks ethylene glycol in their body, it will get converted into oxalic acid. Because of that, this patient will have oxalic acid crystals in the urine. So there will be oxaluria. And one drug which is acid, aspirin, salicylic acid. Second group, ketoacidosis. This ketoacidosis can be part of diabetic ketoacidosis, starvation ketoacidosis, alcoholic ketoacidosis. And third is lactic acidosis. Lactic acidosis. So Yash Agarwal, how does addition of acid anions contribute to persistence of increased anion gap? So I have shown you in the video. So this bicarbonate is being lost and these acid anions are adding up. Because one is lost, other is filling. So the anion gap is maintained. So it is simple physics. See, from the measured compartment, bicarbonate is lost. In the unmeasured compartment, acid anions are being added. See here, bicarbonate is lost. Acid anions are being added. Because of these two, the anion gap is staying like that only. So it is not changing. It is as simple as that. See, because two things are happening, it is making sure the anion gap is staying high. So bicarbonate is being lost, acid anions. See, bicarbonate will be decreasing. Acid anions will be gathering here, so that anion gap increases. Acid anion contributes to unmeasured part. See this part, this is unmeasured part. Lactic acidosis. Lactic acidosis, depending upon the clinical scenario, it can be divided into type A lactic acidosis, type B lactic acidosis. In type A lactic acidosis, either perfusion will be reduced or oxygen reaching the tissues will be reduced. Here, perfusion and oxygenation will be normal, still there is lactic acidosis. Now you know that when is lactic acid produced in your body as a part of anaerobic metabolism. So what are the conditions that causes less perfusion? Anaerobic metabolism means oxygen is less. So what takes oxygen to your tissue? Blood. So in shock, blood is not reaching the tissue. So there will be lactic acidosis. Then in anemia, what carries oxygen to the tissue? Hemoglobin. Now hemoglobin is less oxygen reaching the tissue, lactic acidosis. Then carbon monoxide poisoning. So why in carbon monoxide poisoning there is lactic acidosis even though blood pressure is normal? Hemoglobin present in the body quantity is normal, but that hemoglobin, instead of binding with oxygen, it is completely bound with carbon monoxide. So it cannot carry oxygen to the tissues. Now coming to type B lactic acidosis, this can be further classified into systemic causes, drug related. Now what are the two systems that handle lactic acid in your body? So first system is your liver. Liver will break down lactic acid. So whenever there is liver failure, lactic acid cannot be broken down. So lactic acid accumulates in your body. Kidney is responsible for excretion of lactic acid. Whenever there is kidney failure, there will be lactic acid accumulating in the body. So few drugs such as zidovudine, isoniazid, metformin. These drugs can interfere in various metabolic pathways, ultimately resulting in lactic acidosis. Lactic acidosis, we have type A, type B. Under type B, systemic causes, drug related. And finally, when will all the acids produced in your body not going out? When your kidney is not functioning well, renal failure. So whenever you identify a patient with high anion gap metabolic acidosis, look for these causes. Has this patient taken any toxin or drugs? Is he having ketoacidosis? Possibility of lactic acidosis, possibility of renal failure. So high anion gap is very, very important. So when there is high anion gap with relevant clinical history, always consider it as significant. Now there is a diabetic individual, your ABG is showing high anion gap. So what you should suspect? Possibility of diabetic ketoacidosis. A kidney disease patient showing high anion gap. Possibility that disease has progressed into renal failure. So that's why very important. So kindly remember this sentence. High anion gap with relevant history, especially in ICU, is actually is always taken significant. So you should focus on high. If there is high anion gap, always search for one of these causes. Now coming to normal anion gap metabolic acidosis. Again the same compartments: sodium, chloride, bicarbonate. Okay, between these two we have anion gap. Now the initiating event in normal anion gap metabolic acidosis is not addition of acid. Because of some disease, there is a loss of bicarbonate. Suppose 2 bicarbonate ions are lost. What will your body do is, it will take or it will reabsorb 2 chlorides in return. So there will be chloride reabsorption. So there will be simultaneous chloride reabsorption. Now if you observe here, because there is loss of bicarbonate, it should be called as metabolic acidosis. Bicarbonate is lost, metabolic acidosis. So 2 bicarbonate were lost, 2 chlorides are coming inside. So what will happen to the total value of chloride and bicarbonate? It will remain the same. So the anion gap will remain the same. So it is called as normal anion gap metabolic acidosis. Because chloride is coming back in excess, few books call this type of acidosis as hyperchloremic metabolic acidosis. So this is also called as hyperchloremic metabolic acidosis. Now you should get a valid doubt. Even in high anion gap metabolic acidosis, when bicarbonate was getting consumed as buffer, if chloride was being reabsorbed, the anion gap should have stayed normal. But what is absent here, present there, getting added up immediately, resulting in high anion gap. Your answer should be this acid anion. So this acid anion will quickly accumulate in the unmeasured compartment, always keeping the anion gap high. Whereas normal anion gap metabolic acidosis, it is not due to addition of acid. Because of some disease, bicarbonate is lost from your body. Immediately chloride is getting reabsorbed. Now can you tell me a cause of normal anion gap metabolic acidosis, one disorder in your body or one phenomena in your body where bicarbonate is routinely lost, one phenomena. See, everybody must have experienced it at least once in their lives. Okay, what is that phenomena? It is diarrhea. So in diarrhea, the secretions from the lower GIT are lost. Lower GI secretions are pooled with bicarbonate. Source of that bicarbonate is from the pancreas. So write down diarrhea. In diarrhea. In diarrhea, there is loss of lower GI secretions. There is loss of lower GI secretions rich in bicarbonate. Because bicarbonate is lost, there will be metabolic acidosis. I don't know why everybody is saying RT. I asked you a common condition. So commonly you get renal tubular acidosis. See, right now in my 10 years of practice, I have seen only 3 or 4 cases of renal tubular acidosis. Okay, I don't do nephrology practice actually, I do pulmonology practice only. But even our nephrologists, when there is some APG doubt, they come and ask us. So we haven't seen renal tubular acidosis that commonly. See, once again, in medicine, common sense, common things are first. So don't worry about all the rare cases. First, try to identify common diseases. Know to treat common diseases, so you will be a successful practitioner. Then next, what happens in vomiting? What happens in vomiting? In vomiting, there is loss of upper GI secretions. There is loss of upper GI secretions. What is your upper GI secretions containing? Acid. So rich in acid. Because acid is lost from the body. What will this body develop? Metabolic alkalosis. So very important concept that we are discussing here. Diarrhea, loss of lower GI secretions rich in bicarbonate. So patient generally lands up in metabolic acidosis. Vomiting, there is loss of upper GI secretions rich in acid. So patient will land up in metabolic alkalosis. In the same way, let us see what happens in hyperaldosteronism. What happens in hyperaldosteronism and what tends to happen in hypoaldosteronism. First of all, tell me students, what is the function of the enzyme called as or hormone called as aldosterone, especially on the collecting duct? Okay, what is the function of aldosterone in your body, especially in the collecting duct? So what it will do, it will facilitate sodium reabsorption, sodium and water reabsorption. So if 3 sodium are coming into your body, 2 K plus and 1 H plus will be lost in the urine. Now if there is hyperaldosteronism, excess sodium is coming into your body. So for whatever sodium excess is coming into the body, what will be lost from your body in excess? H plus and K plus. Because H plus is lost, patient will develop metabolic alkalosis. Because K plus is lost, patient will develop hypokalemia due to increased sodium reabsorption. Because of increased sodium reabsorption, there is loss of H plus and K plus from body. There is loss of H plus and K plus from body. Because H plus is lost, patient will have metabolic alkalosis. Because K plus is lost, patient will have hypokalemia. Then coming to hypoaldosteronism. Now there is no sufficient aldosterone in your body. So sodium will not be properly reabsorbed. If sodium is not coming into your body, what will not go out from your body? H plus and K plus. So H plus and K plus will be retained in the body. If H plus increases, metabolic acidosis. If K plus increases, hyperkalemia due to decreased sodium reabsorption. H plus and K plus retained in body. That results in metabolic acidosis plus hyperkalemia. Now you should get a valid doubt. Why loss of H plus is called as metabolic alkalosis? Why retention of H plus is called as metabolic acidosis? See, again it follows the acid-base equilibrium. So in my body, H plus and bicarbonate will try to stay in equilibrium, and there will be few free H plus and few free bicarbonate maintaining the pH. Now because of some disease, if suddenly H plus increase in my body, what will happen? All the free bicarbonate will come and bind to this H plus. So whenever the free bicarbonate are decreasing, what will happen? Any decrease in bicarbonate is called as metabolic acidosis. Now whenever there is H plus loss, what will increase in the body? Free bicarbonate will increase. So anywhere if there is increase in bicarbonate, what is that phenomena called as? Metabolic alkalosis. So ultimate point that you need to know here is, when there is hyperaldosteronism, the end result will be metabolic alkalosis, hypokalemia. When there is hypoaldosteronism, the end result will be metabolic acidosis and hyperkalemia. With this background, let us see some important causes of normal anion gap metabolic acidosis. The causes of normal anion gap metabolic acidosis, it can be classified into two. One side we have GIT causes, on other side we have renal causes. What is the most frequently seen GIT cause? Yes, nothing but diarrhea. Causes of high normal anion gap metabolic acidosis. So I am discussing what are the causes of normal anion gap metabolic acidosis. Next is an enterocutaneous fistula. Pancreatic fistula, and a complex surgery called as ureterosigmoidostomy. Okay. Now why in diarrhea there is normal anion gap metabolic acidosis? Because in diarrhea there is loss of GI secretions rich in bicarbonate. So why in enterocutaneous fistula? What is meant by entero? Entero means intestine. Cutaneous means skin. Fistula means opening. So there is a opening from your intestine onto the skin. So through that opening, what can be lost? Intestinal secretions rich in bicarbonate. Then what is pancreatic fistula? So from the pancreas, there is an opening to outside. What does pancreatic secretions contain? See, pancreas or the source of bicarbonate. Pancreatic secretions can be rich in bicarbonate. So through the fistula, secretions rich in bicarbonate are lost. So that will result in again metabolic acidosis. Then coming to ureterosigmoidostomy. So this is ureter and this is sigmoid colon. So when this surgery is generally done, whenever there is bladder cancer, for example, now ureters cannot drain into the urinary bladder. So I am going to divert the ureter into the sigmoid colon. So we are going to divert the ureter into the sigmoid colon. So whenever ureters are diverted into the sigmoid colon, urine is now accumulating in the sigmoid colon. So what does urine contain? Urine is rich in chloride. So whenever excess chloride reaches the sigmoid colon, now my sigmoid colon will feel that this fellow has taken chloride rich diet. So what will it do? So my body will start reabsorbing chloride. So chloride will be reabsorbed in excess. So for whatever chloride has been reabsorbed, a negative is reabsorbed. A negative called as bicarbonate will be sent out. So bicarbonate will be lost in excreta. So why this is not happening in normal individuals routinely? Because in normal individuals routinely never this much amount of chloride will be coming continuously into the intestine. Because your ureter is permanently connected to sigmoid colon, continuously chloride will be coming into the colon. So your body will feel this patient has taken chloride rich diet. So chloride will be reabsorbed. For whatever chloride is being reabsorbed, bicarbonate will be lost in patient's excreta. Because bicarbonate is lost, there will be metabolic acidosis, chloride reabsorption has happened. So the anion gap will be normal. Now coming to the renal causes, first group will be the renal tubular acidosis. The renal tubular acidosis, written as RTA. So in this we have first combination type 1 and type 2 RTA. So why did I write these two together? Because they are associated with metabolic acidosis with hypokalemia. Then we have type 4 RTA. So this type 4 RTA is the most common form, and this is associated with metabolic acidosis with hyperkalemia. Metabolic acidosis with hyperkalemia. So is renal tubular acidosis dealt in your nephrology students? Yes or no? Renal tubular acidosis, is it dealt in nephrology? Yes. I think it must have been covered in nephrology. So you'll just see some basics here, only basics. So type 4 renal tubular acidosis, first we will see why there is metabolic acidosis and hyperkalemia. So this type 4 renal tubular acidosis is actually due to aldosterone resistance or aldosterone deficiency. So here in these patients, the type 4 RTA is due to aldosterone resistance or deficiency. It means either aldosterone is not working properly or aldosterone is less in your body. So this is something similar to hypoaldosteronism. previously discussed. What will hypoaldosteronism ultimately result in? It results in metabolic acidosis, hyperkalemia. And next important group of causes, renal causes, is drugs. So drugs such as ACE inhibitors, aldosterone antagonist, carbonic anhydrase inhibitors, carbonic anhydrase inhibitors. Now, why will ACE inhibitors and aldosterone antagonists be responsible for metabolic acidosis? So, whenever I give ACE inhibitors, aldosterone will not be produced. Whenever I give aldosterone antagonist, aldosterone will not function. So these two drugs will also result in a condition similar to hypoaldosteronism. So what will be the end result in hypoaldosteronism? It is metabolic acidosis, hyperkalemia. So what will be the side effect of ACE inhibitors? Metabolic acidosis, hyperkalemia. Side effect of aldosterone antagonist, metabolic acidosis, hyperkalemia. Now, why will carbonic anhydrase inhibitor be responsible for metabolic acidosis? In my kidney, in the proximal convoluted tubule, carbonic anhydrase is required for bicarbonate reabsorption. Now, if I inhibit that enzyme, bicarbonate will not be reabsorbed. It will be lost in urine. So, when I give carbonic anhydrase inhibitor, there will be increased loss of bicarbonate in urine. So, whenever bicarbonate is lost from the body, what is that phenomena called as metabolic acidosis? So, in this table, we have discussed the GIT causes and the renal causes. So, within the renal cause, type 4 RTA is the most common type. It presents with metabolic acidosis, hyperkalemia. So, we have understood why there is metabolic acidosis and hyperkalemia here, because type 4 RTA is a state similar to hypoaldosteronism. Now, why in type 1 and type 2 RTA there is metabolic acidosis and hypokalemia? So, you have been already told about type 1 and type 2 RTA very well in nephrology. So, here we will only discuss the ABG abnormalities. Type 1 also called as distal RTA, type 2 also called as proximal RTA. Now, let us see the defects here. In type 1 or distal RTA, the problem is there will be decreased H plus excretion in distal nephron. So, ultimate defect is decrease in H plus excretion in distal nephron, usually in the collecting duct. Now, first of all, let us see what is normally happening in the distal nephron. Let us consider this is the tubule containing urine, and let this be the body side containing cells. So, let this be the body side. Now, normally, whatever I write with this color, it is a normal phenomenon. Normally, in the collecting duct, from the urine, if 3 Na plus are coming towards the body, generally 2 K plus and 1 H plus will be going out in the urine. Now, in type 1 RTA, what is the problem? This H plus excretion is not happening. So, from the body, this H plus will not go out. So H plus gradually increases in the body. Because H plus is increasing, there will be metabolic acidosis. Now what is the other association in these two, type 1 and type 2 renal tubular acidosis? There is also hypokalemia. Now why there is hypokalemia? Now if you observe here, in a normal individual, if 3 Na plus are coming into the body, 2 K plus and 1 H plus is getting excreted. But in type 1 RTA, this H plus is not at all coming out. My body is always greedy about sodium. So my body will take the third sodium also by kicking a K plus out. So in a normal individual, when 3 sodium were taken, only 2 K plus were coming out because there was an H plus coming out. But in type 1 RTA, H plus is not coming out. So what will my body do? It will take the third sodium by throwing third K plus out. So in normal individual, only 2 K plus are lost in a single cycle. Whereas in a patient with type 1 RTA, 3 potassium are lost. When compared to normal individual, excess potassium is lost. So there will be hypokalemia. So there is excess K plus loss for sodium reabsorption. So there can be excess K plus loss for sodium reabsorption. Now coming to type 2, also called as proximal RTA. Here the problem is decreased bicarbonate reabsorption. Decreased bicarbonate reabsorption in proximal convoluted tubule. So again, this will be the diagram. Urine, let this be the body side and let this be the cells. Normally in the PCT, there should be bicarbonate reabsorption. Bicarbonate should be reabsorbed. Bicarbonate should be reabsorbed. In type 2 RTA, the problem is there is decreased bicarbonate reabsorption in the PCT. Because bicarbonate is not getting reabsorbed, there will be loss of bicarbonate in the urine. Because of that, there will be metabolic acidosis. Bicarbonate is getting lost in the urine, not coming into the body. So there is metabolic acidosis. Now why there is metabolic alkalosis? So whenever bicarbonate is lost in excess, there is a remote mechanism happening in your body called as excess bicarbonate in urine. Excess bicarbonate in urine can stimulate kaliuresis. So what is happening here? Kaliuresis means potassium loss in urine. This bicarbonate is a negatively charged ion. So whenever it is going out in excess, it will not go single. It can mingle with a positive. So along with that, it can drag a positive charge called as potassium with it. So here bicarbonate is lost, metabolic acidosis. Along with that, it can drag some amount of potassium, so there will be hypokalemia. So both in type 1 and type 2 RTA, there is metabolic acidosis with hypokalemia. So we have discussed the precise mechanisms here. Whereas most common type is type 4 RTA. In type 4 RTA, what do you generally see? We see metabolic acidosis with hyperkalemia. So this is regarding metabolic acidosis. Next we have metabolic alkalosis. For metabolic alkalosis, you should understand the importance of initiating event, what is this initiating event, and what is this persisting event. Initiating event and what is this persisting event. To understand this, let us see a previous AIIMS question. So they have mentioned in the history a 25-year-old male. He was having history of vomiting, very severe, so he was brought to the emergency department. On examination, his blood pressure was low. So in the emergency department, now no active vomiting, and ABG was showing severe metabolic alkalosis. Now the question is, how to treat metabolic alkalosis here? Now let us try to understand the clinical scenario. What is the reason for metabolic alkalosis here? What is the disease that initiated metabolic alkalosis? So patient is having history of vomiting. So because of vomiting, there must be loss of acid that must have started metabolic alkalosis. Now when he was brought to the emergency department, his BP is low, very important point, and no active vomiting. Now the vomiting has completely subsided, but still there is severe metabolic alkalosis. Now what might be the reason for persistence of metabolic alkalosis in this patient? Now try to understand the concept here. So in this patient, the metabolic alkalosis has started because of vomiting. So whenever somebody vomits, not only acid, fluid from your body is also lost. Whenever your body has to choose between acid-base status and fluid status, which will it always choose first? Fluid status. Because without adequate fluid, your organs cannot function properly. So to conserve fluid, what is the mechanism getting activated in this patient? What is that mechanism called as? Renin-angiotensin-aldosterone system. So RAS will get activated. Now what is the role of this RAS? Ultimately there will be increased aldosterone. And what will excess aldosterone do? It will cause sodium and water retention. At the cost of what will be lost? K plus will be lost. So patient will develop hypokalemia. Along with K plus, what else will be lost? H plus will be lost. So patient will develop metabolic alkalosis. Now try to understand this concept. This patient started with metabolic alkalosis and his body's defense mechanism is also causing persistence of metabolic alkalosis. So this is a typical example of extracellular fluid volume contraction. So the volume in his body has decreased. That has triggered secondary hyperaldosteronism, and that is responsible for persistence of metabolic alkalosis. See this sequence. So extracellular fluid volume contraction, hypotension, secondary hyperaldosteronism. Now in this patient, the reason for persistence of severe metabolic alkalosis is that volume contraction responsible for hypotension, responsible for secondary hyperaldosteronism. Now how to treat the metabolic alkalosis here? Now what is the reason for persistence of metabolic alkalosis? Volume contraction. Now how will you treat volume contraction? So whenever a patient is having very low BP, what will be the general fluid of choice? Saline, normal saline. Now if you give normal saline to this patient, his volume status will be corrected. So once his volume status BP is corrected, the activation of renin-angiotensin system will be lost. So the ABG will come back to normal. So this is a metabolic alkalosis which can be corrected by saline or which will respond to saline. So this is a metabolic alkalosis which can be corrected by saline and which will respond to saline. So it is called as saline responsive metabolic alkalosis. So Yash Agarwal, sir, please explain after RAS. See, very simple. Activation of renin-angiotensin, aldosterone. So in that important hormone is aldosterone. Okay. So what will aldosterone do? So it will cause sodium and water retention. Already I have discussed that. So because of sodium retention, what will happen? There will be loss of K plus potassium and loss of H plus. Loss of K plus will result in hypokalemia. Loss of H plus will result in metabolic alkalosis. If you observe here, the patient first started as metabolic alkalosis and his body's defense mechanism is responsible for persistence of metabolic alkalosis. Now apply the same concept here. In this patient, now there is no active vomiting, but still there is metabolic alkalosis. What might be the reason for metabolic alkalosis? Volume contraction, hypotension, his BP is low. How will you correct metabolic alkalosis here? Give him saline, his BP will improve. So that will cut off the trigger for renin-angiotensin aldosterone system. So because that is not getting activated now, his pH will come back to normal, his ABG will come back to normal. So this is a metabolic alkalosis which is responding to saline. So it is called as saline responsive metabolic alkalosis. So rule number 1. Metabolic alkalosis predominantly due to volume contraction. See, if volume contraction is responsible for metabolic alkalosis, what will be the treatment here? Correction of the volume contraction. How will you correct it? By giving saline. So this is called as saline responsive metabolic alkalosis, because volume contraction itself can cause metabolic alkalosis. How will it cause? By secondary hyperaldosteronism. Now coming to the next patient. This patient, since his childhood, his adrenals are producing excess aldosterone. So he is having primary hyperaldosteronism. Now in a patient with primary hyperaldosteronism, what will be the fluid status? See, always aldosterone is hitting your kidneys. So there will be sodium and water retention. So patient will have extracellular fluid volume expansion and hypertension. What will be his ABG status? This is aldosterone excess. So he will be having sodium retention. So K plus and H plus will be going out. So he will be having metabolic alkalosis. Now this patient is also having metabolic alkalosis with coexisting hypertension. Now in this patient, what will happen if you give saline? Already there is fluid overload. See, already there is excess fluid. Now if you give saline in this patient will develop fluid overload and he may die of some cardiac failure. Now the problem here is this is also metabolic alkalosis, and it will not respond to saline, and you cannot give saline here. So it is called saline unresponsive metabolic alkalosis. Saline unresponsive metabolic alkalosis. See, metabolic alkalosis with coexisting hypertension. If already there is hypertension, there is no point in giving saline in this patient. So it is called as saline unresponsive metabolic alkalosis. So why did they classify like saline responsive and unresponsive is, see, to easily treat the patient. Metabolic alkalosis is there in 2 patients. If he is having some volume contraction, directly give saline, patient will improve. If he is having hypertension, so make sure you are evaluating further and treat the underlying disease. So 2 rules. Metabolic alkalosis predominantly due to volume contraction. It will be saline responsive because volume contraction itself will cause metabolic alkalosis. Rule number 2, metabolic alkalosis with coexisting hypertension. You cannot give saline here. So it will be saline unresponsive metabolic alkalosis, because already there is fluid excess. There is no point in dumping extra saline into this patient's body. So write down the mechanisms First mechanism, extracellular fluid volume contraction, hypotension, secondary hyperaldosteronism. Because of some primary mineralocorticoid excess. There can be extracellular fluid volume expansion. Along with that, patient will be having hypertension. Now tell me, out of these two mechanisms, which will be saline responsive? So the first mechanism will be saline responsive. So write down rule number 1. Metabolic alkalosis predominantly due to volume contraction, it will be saline responsive. So why is it so? Volume contraction itself will cause metabolic alkalosis. What is the mechanism? Hypotension, secondary hyperaldosteronism. What are the examples? Vomiting. If a patient does by himself, it is vomiting. Where do you put Ryle's tube? In the stomach. And if you aspirate the contents out, there will be loss of upper GI secretions rich in acid. So vomiting is what patient is doing voluntarily. So Ryle's tube, you put it in the patient's stomach, and if you aspirate the contents in excess, so there can be again metabolic alkalosis, volume loss. Then diuretics. You must be knowing diuretics will also result in volume loss, volume contraction, ultimately resulting in metabolic alkalosis. Now rule number 2. Metabolic alkalosis with coexisting hypertension. So whenever there is hypertension, there is no point in giving saline. So it will be saline unresponsive. Examples: primary hyperaldosteronism, Cushing's syndrome, renin secreting tumor. Why in these three conditions there is metabolic alkalosis with coexisting hypertension? Primary hyperaldosteronism is nothing but primary mineralocorticoid excess. Then in Cushing's syndrome, it is glucocorticoid excess. Cushing's syndrome is generally glucocorticoid excess. But still, patient will have metabolic alkalosis and hypertension. What is the reason behind that? Because glucocorticoids can have some amount of mineralocorticoid action. So the glucocorticoids can have some amount of mineralocorticoid action. Because of that mineralocorticoid action, there will be metabolic alkalosis, hypertension. Then renin secreting tumor. So whenever renin is secreted in excess, ultimately aldosterone will be produced in excess. So these three conditions will be similar to aldosterone excess states. So there will be metabolic alkalosis with hypertension. Apart from this, there is another parameter which will be helpful to differentiate these two. That parameter is urinary chloride levels. In saline responsive case, urinary chloride levels was found to be less than 20 milliequivalents. Whereas in saline unresponsive case, urinary chloride level was found to be more than 20 milliequivalents. Now what is the reason behind this? Again, this is based on our common sense only. Now in saline responsive cause, these patients are generally associated with volume contraction. So whenever there is less volume in your body, what will your kidney try to do? Will it try to conserve fluid or will it try to excrete fluid? It will try to conserve fluid. So whenever fluid is getting conserved, so how is fluid getting conserved? By reabsorption of salt. So there will be salt and water reabsorption. So what does salt contain? Na plus Cl minus. So because excess chloride is getting reabsorbed into the body, so within the urine the chloride lost will be less. So very simple concept. In majority of saline responsive cases, these patients will be having volume contraction. So to conserve fluid, what will your body do? It will cause salt and water reabsorption. So salt and water is getting reabsorbed. So what does salt contain? Chloride. Because chloride is being reabsorbed, chloride lost in the urine will be less. So urinary chloride level will be less than 20 milliequivalents in saline responsive cases. Now coming to saline unresponsive. Saline unresponsive causes generally will have hypertension. So whenever there is fluid excess in the body, volume excess in the body, so there is no need for the patient to conserve salt. See, whenever there is a patient with hypertension, when he reaches to my clinic, what will be the first word that I write in the treatment? So what will be the first sentence that I write in the treatment? Yes, it will be salt restricted diet. Same thing, your kidney will not try to reabsorb excess salt. Because excess salt is not getting reabsorbed, the chloride will be lost in the urine. So urinary chloride will be more than 20 milliequivalents. So here the concept is saline unresponsive causes are associated with hypertension. So there is no need for your kidney to reabsorb salt. So it can be lost in the urine. So because chloride is lost in the urine, urinary chloride will be more than 20 milliequivalents. Urinary chloride will be more than 20 milliequivalents. Now coming to rule number 3. Metabolic alkalosis due to some permanent genetic defects of renal tubules. Some permanent genetic defects of renal tubules, such as Bartter syndrome, Gitelman syndrome, and Liddle's syndrome. These are some permanent genetic defects of renal tubules. So these will also be saline unresponsive because these are some irreversible genetic defects. Even if you give saline in this patient, there will be no response. So three important rules: metabolic alkalosis predominantly due to volume contraction, saline responsive. Metabolic alkalosis with coexisting hypertension, saline unresponsive. Metabolic alkalosis due to genetic defects of renal tubules such as Bartter syndrome, Gitelman syndrome, Liddle syndrome. So in these three also there will be metabolic alkalosis which is saline unresponsive. Because these are some primary genetic defects, even if you give saline there will be no response. Now let us see why in these three conditions there is metabolic alkalosis and why it is saline unresponsive. So make a table: Bartter syndrome, Gitelman syndrome, Liddle syndrome, only the ABG parameters. So you must be knowing Bartter syndrome is due to decreased reabsorption. Decreased reabsorption of Na plus K plus 2Cl minus in loop of Henle. Because sodium is not getting reabsorbed. Its best friend. What is the best friend of sodium? Usually sodium and what else will be reabsorbed together? Water. Because sodium is not getting reabsorbed, water will not be reabsorbed. So there will be volume loss. Whenever there is volume loss, there will be activation of renin, angiotensin, aldosterone system. So whenever aldosterone activity increases, what will be the end result? Metabolic alkalosis. Along with that, hypokalemia. Then Gitelman syndrome. This is decreased reabsorption. Gitelman syndrome is decreased reabsorption of Na plus Cl minus in distal tubule. Again here sodium is not reabsorbed. That will result in volume loss. That will result in activation of RAS. So this patient will also have metabolic alkalosis with hypokalemia. Now what is Liddle syndrome? So Liddle syndrome happens due to hyperfunctioning of a channel called as epithelial sodium channel in collecting duct. If you observe these three diseases, they are in a sequence. So the first part is loop of Henle, the next part distal tubule, the next part collecting duct. So in loop of Henle, Bartter syndrome, distal tubule, Gitelman syndrome can happen. In collecting duct, Liddle syndrome can happen. Now what is the problem happening in Liddle syndrome? Now let us consider this is the urine, this is the body side, and let this be the cells. So normally if 3 sodium are coming towards the body, 2 K plus and 1 H plus will be lost. Now in Liddle syndrome what is happening? There is hyperfunctioning of ENaC. Instead of 3 sodium, 6 sodium are going into the body. See, extra sodium are taken in. So for extra sodium taken in, what will be lost? Extra K plus and extra H plus. in a normal individual, in a single cycle only 3 sodium were coming in. But in Liddle syndrome, 6 sodium are coming in. So when 6 sodium are coming in, there will be excess loss of K plus and H plus. Because excess K plus and H plus are lost when compared to normal individual, there will be metabolic alkalosis and hypokalemia. Then what will happen to blood pressure here? There is excess sodium reabsorption. So whenever excess sodium is reabsorbed, water will also be reabsorbed along with that. So this patient will have hypertension. This patient will have hypertension. Now we have understood why in all these three there is metabolic alkalosis. And I told you these three are also saline unresponsive. First, let us start with Liddle syndrome. So why in Liddle syndrome the metabolic alkalosis is saline unresponsive? See, already this patient is having hypertension. So there is no point in giving saline to him. Already there is hypertension, fluid overload, no point in giving saline to him. Now in Bartter syndrome and Gitelman syndrome, so there is volume loss that is responsible, for metabolic alkalosis, but still this is saline unresponsive metabolic alkalosis. So what is the reason behind that? See, now if you consider this is your body filled with fluid, okay? So there is some volume loss resulting in volume contraction. So because of this volume contraction, this patient, for example, has developed metabolic alkalosis. Now if I replace volume, now if I fill this bottle back to its tip, now the volume is replaced. So the trigger for renin-angiotensin system will be abolished. So patient's ABG can come back to normal. Now suppose this bottle is containing multiple holes. Now this bottle is containing multiple holes. Now if I fill water to a bottle filled with holes, after some time through the holes all the water will come out. So because of that, always there will be volume contraction happening in the body, resulting in renin-angiotensin aldosterone system activation and metabolic alkalosis. So same concept try to apply in Bartter syndrome. See, what is saline? It contains sodium and chloride. So is sodium and chloride getting reabsorbed in Bartter syndrome? No. So even if I give saline, so what is happening? It is not getting reabsorbed properly. It will be lost through the loop of Henle. Now in Gitelman syndrome, what is not getting reabsorbed? Na plus Cl minus. So what is saline? Na plus Cl minus. So in Gitelman syndrome also, even if I give saline, it will not be properly reabsorbed. So it is just like trying to fill a bottle with holes. So where are the holes present in Bartter syndrome? Loop of Henle. So what is the name of the hole? Na plus, K plus, 2Cl minus. So where are the holes present in Gitelman syndrome? In distal tubule. So what is the name of the hole? Na plus, Cl minus. So in Bartter syndrome and Gitelman syndrome, even if you give saline, it will not be ultimately properly reabsorbed. So there will be continuing volume loss resulting in metabolic alkalosis and hypokalemia. So this is a discussion regarding metabolic alkalosis. What is saline responsive? What is saline unresponsive? So why there is metabolic alkalosis in these genetic defects? Then coming to respiratory acidosis. I already have discussed in detail regarding respiratory acidosis. Where is that? So respiratory acidosis, where did we discuss? It is nothing but hypercapnia. Where did we discuss about hypercapnia? Type 2 respiratory failure. Type 2 respiratory failure. Hypercapnia, type 2 respiratory failure. So the causes of respiratory acidosis is well discussed in type 2 respiratory failure. Then coming to respiratory alkalosis. So write down this respiratory alkalosis, especially the chronic form. Chronic respiratory alkalosis is considered as most common acid-base disorder in critically ill patients. Most common acid-base disorder in critically ill patients. So why it is so? Once you understand the causes of respiratory alkalosis, you will know it better. Now, first group of cause, it can be due to pain. It can be due to panic. Few females will have psychogenic hyperventilation. See, in pain, people can hyperventilate. In panic, in fear, people can hyperventilate. Few young females will be having psychogenic hyperventilation. And progesterone. See, progesterone can directly stimulate respiratory center. Progesterone can directly stimulate respiratory center. Second group of causes, toxins getting accumulated in sepsis and also cirrhosis. So these toxins can also stimulate respiration. And diseases responsible for hypoxemia. So diseases responsible for hypoxemia, they can stimulate chemoreceptors. So whenever peripheral chemoreceptors are stimulated, there will be hyperventilation. So when there is hyperventilation, there will be CO2 washout. So what is CO2 washout? It is nothing but respiratory alkalosis. Then mechanical hyperventilation. I have connected a patient to mechanical ventilator and the patient's respiratory rate is not getting adjusted with mechanical ventilator's respiratory rate. Suppose I have increased the ventilation rate to 20 per minute and patient's baseline rate was only 12 per minute. So now there will be some amount of hyperventilation. So whenever patient's respiratory rate is unable to adjust with mechanical ventilator's respiratory rate, there will be some amount of hyperventilation and CO2 washout. Now, why is this chronic respiratory alkalosis considered as most common acid-base disorder in critically ill patient? A critically ill patient might be having pain. He will be in panic. He may be having sepsis. He might be having hypoxemia, or he might be connected to a mechanical ventilator. So majority of these conditions are seen in critically ill patients. That's why it was considered as most common acid-base abnormality. Then coming to drugs called as aspirin. So where did we come across aspirin previously? High anion gap metabolic acidosis. So this aspirin also can stimulate respiratory center. It can directly stimulate respiratory center, resulting in respiratory alkalosis. This is more common. Respiratory alkalosis is more common, but very rarely in very high doses of aspirin. Very high doses of aspirin. It can cause severe metabolic acidosis, resulting in decreased functioning of respiratory center, respiratory depression, ultimately respiratory acidosis. but this phenomena is very rare in clinical practice. So aspirin generally causes respiratory alkalosis, and also high anion gap metabolic acidosis. So very rarely in severe doses or in severe conditions, it can cause respiratory depression that can result in respiratory acidosis. Respiratory acidosis is rare. So these are the causes of respiratory alkalosis. So students, we have discussed all the individual acid-base disorders: metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Now coming to the next important topic, mixed acid-base disorders. So we have discussed individual acid-base disorders. Now let us see mixed acid-base disorders. Now for mixed acid-base disorders, clinical history is very important. So without clinical history, it is very difficult to interpret mixed acid-base disorder. Clinical history very important. Now let us see some mixed acid-base disorders with examples. Now for example, there was a patient with COPD, and because of COPD, his CO2 has increased from normal value of 40 to 60. Now as a compensatory mechanism, bicarbonate should increase from normal value of 26 to how much? See, CO2 has increased from 40 to 60. CO2 has increased from 40 to 60, 20. So bicarbonate should increase from how much? From 26 to 34. So if bicarbonate has reached 34, it is adequate compensatory response. Now there is another patient. This patient, he is having COPD along with that some vomiting. So his CO2 has increased from 40 to 60. So normally bicarbonate in this condition should reach to 34, but it has increased to 36. So whenever CO2 increases from 40 to 60, bicarbonate should stay at 34. If it is increasing, any additional increase in bicarbonate than expected value is additional metabolic alkalosis. See whether this fellow has developed some vomiting. Now another COPD patient, his CO2 has increased from 40 to 60. So to call it as an adequate compensatory response, his bicarbonate should reach to 34. If at all his bicarbonate has decreased to 30, what does it mean? So whenever CO2 increases from 40 to 60, his bicarbonate should reach 34. If it is decreasing, it means there is some other additional disorder which is trying to decrease bicarbonate. Any disorder that tries to decrease bicarbonate, it is called as additional metabolic acidosis. See whether this fellow has developed some diarrhea. Now if you do some questions, you will understand this better. So there was a patient with COPD. So without any other clinical abnormality, this was his ABG. So quickly tell me, what is the disorder? pH decreased, CO2 increased, bicarbonate increased. Any decrease in pH anywhere is acidosis. Change in pH with respect to parameters opposite. So what should be the primary? Respiratory. Now coming to compensatory response. So this is a chronic disease. So in a chronic disease, if CO2 increases from normal value of 40 to 60, it has increased by 20. So what should be the value of bicarbonate? Bicarbonate should increase from normal value of 26 to how much? For 10 it is 4, for 20 it is 8, it should reach 34. So in this question, given bicarbonate is 34, expected is also 34. given and expected or correlating. So if both are correlating, adequate compensatory response, respiratory acidosis with compensatory metabolic alkalosis. So no issue here. Now there is another patient with vomiting, COPD with vomiting. These were the parameters: pH reduced, PaCO2 increased, bicarbonate increased. Any decrease in pH, acidosis. Change in pH with respect to parameters, opposite. So the primary is respiratory. So whenever there is a primary respiratory disorder, if CO2 has increased to 60, as a compensatory phenomena, bicarbonate should stay at 34. But here bicarbonate has increased beyond that. So in this question, given bicarbonate is very much more than expected bicarbonate. How much is the expected bicarbonate? 34. Given is high. So whenever there is increase in bicarbonate when compared to expected, it means there is some other additional disorder trying to increase bicarbonate. So any disorder that is trying to increase bicarbonate should be considered as additional metabolic alkalosis. And once again, check the history. What might be the reason for this additional metabolic alkalosis? Patient is vomiting. Patient with COPD and diarrhea. These were the parameters. So tell me the acid-base disorder: pH decrease, CO2 increase, bicarbonate increase. Any decrease in pH is acidosis. Change in pH with respect to parameters, it is opposite. So what is primary? Respiratory. In a primary respiratory acidosis, when CO2 increases to 60 as a compensatory phenomena, bicarbonate should be at 34. But here it has decreased to 30. So in this question, given bicarbonate is very much less than expected bicarbonate, it means there is some other disorder that has decreased the bicarbonate. So any disorder that tries to decrease bicarbonate should be called as additional metabolic acidosis. So what might be the reason for this additional metabolic acidosis? It is diarrhea. So in very simple words, I will tell you, if CO2 reaches to this level, as a compensatory phenomena, bicarbonate should also reach to this level. If bicarbonate has increased beyond the compensatory value, it means there is some other disorder try to increase bicarbonate. Any disorder that is trying to increase bicarbonate is called as additional metabolic alkalosis. In the same way, when CO2 increases to this level, bicarbonate should reach to this level. If it is decreasing beyond that, so what does it mean? There is some other disorder trying to decrease the bicarbonate. So anything that tries to decrease bicarbonate is additional metabolic acidosis. And check the history and interpret accordingly. Now this is how to interpret a mixed acid-base disorder with respect to a primary respiratory disorder. Now let us discuss with respect to primary metabolic disorder. Again a clinical scenario. There was a patient with diabetic ketoacidosis. So because of diabetic ketoacidosis, his bicarbonate value from the normal value has decreased to 10 milliequivalents. So as a compensatory phenomena, his CO2 should come down to the range of 21 to 25. So how did I calculate 21 to 25? With the help of the Winter's formula. Now instead of that, when bicarbonate has decreased to 10, his CO2 instead of reaching to 21 to 25, it has decreased beyond that. So for example, it has decreased to 15. So what does it mean? Body's compensatory response can only bring it to 21. If it is decreasing beyond that, there is some other disorder which is causing CO2 washout. See whether this fellow, because of panic, he is doing some hyperventilation. Now another patient with DKA, his bicarbonate has decreased to 10. As a compensatory phenomena, CO2 should come down to 21 to 25 mmHg. But his CO2 has increased to 35. See, whenever there is bicarbonate decline to 10, CO2 should come down to 21 to 25. If it is increasing beyond that, there is some other disorder trying to increase CO2. So anything that tries to increase CO2 is additional respiratory acidosis. So this is very, very important in this patient, because in diabetic ketoacidosis there is a complication called as diabetic ketoacidotic coma, where there will be respiratory depression that will cause gradual increase in CO2. In simple words, when bicarbonate decreases to this level, okay, CO2 should also come to this level. If it is decreasing beyond it, it means there is additional respiratory alkalosis. If it has increased, there can be additional respiratory acidosis. So write down with clinical scenario, patient with DKA, these were the ABG parameters. So quickly tell me, what is the primary acid base disorder? So all or decline. So decrease in pH is acidosis. Change in pH with respect to parameter, same direction. So it is metabolic acidosis. So whenever there is a primary metabolic acidosis, how will you calculate respiratory compensation? Expected CO2 1.5 into 10 plus 8 plus or minus 2. So 15 plus 8 plus or minus 2. So this will be 21 to 25. Given CO2 is 22, expected is also correlating. So given CO2 is correlating with expected CO2. What should be the answer? Metabolic acidosis with compensatory respiratory alkalosis, a simple acid base disorder. Next scenario. There is a patient with DKA and he is very, very anxious. pH reduced, CO2 reduced, bicarbonate reduced. Because all are decreased, it is metabolic acidosis. Whenever there is a primary metabolic acidosis, bicarbonate has decreased to 10. To call it as a compensatory phenomena, CO2 should come down to 21 to 25. But it has decreased beyond that. In this question, given CO2 is very much less than expected CO2. So whenever given CO2 is very much less, it means there is some other disorder trying to cause CO2 washout. So anything that results in CO2 washout, additional respiratory alkalosis. What might be the reason for respiratory alkalosis here? Patient is anxious, so he might be hyperventilating. Patient with DKA and altered sensoria. His pH reduced, CO2 reduced, bicarbonate reduced. This is nothing but metabolic acidosis. When there is a primary metabolic acidosis, bicarbonate has decreased to 10. CO2 should be 21 to 25, but it is gradually increasing to 34. In this question, given CO2 is very much higher than expected CO2. Whenever given CO2 is higher than expected CO2, it means there is some additional respiratory acidosis, some disorder causing CO2 retention. Now, what might be the reason in this patient? Patient is in altered sensoria. It means there might be some diabetic ketoacidotic coma. In diabetic ketoacidosis, there is a complication called a diabetic ketoacidotic coma, where there will be respiratory depression that will gradually increase CO2 levels. So this is how you should interpret mixed acid-base disorders. This is how you should interpret mixed acid-base disorders. Now coming to ABG sampling. So you can do it on yourself to understand better. So for ABG sampling, which blood is used? Is it arterial blood or venous blood? Your answer should be arterial blood. And most commonly, we take it from the radial artery. Whenever I want to puncture radial artery, I should make sure my ulnar artery is patent. Why? What is the reason? Whenever I puncture my radial artery, transiently the circulation to these fingers will stop. If my ulnar artery is not patent properly, so this hand can develop ischemia. So to test the patency of ulnar artery, we do a special test called as modified Allen's test. So in modified Allen's test, what you do is you are going to tightly hold your wrist like this. So by doing this, you can block both the radial and ulnar, and you are going to close your hand. After few seconds, you will open your hand. Now your hand will be very pale because you have obstructed the flow to this hand. Both ulnar and radial you have compressed. Now slowly you should release the pressure from ulnar artery. On release of pressure from ulnar artery, if your hand turns pink, it means ulnar artery is patent. Ulnar artery is patent means Allen's test is positive. Allen's test positive means you can poke radial artery. Try to understand this phenomena. Everything starts with the letter P. On release of pressure from ulnar artery, if your hand turns pink, it means ulnar artery patent. Ulnar artery patent means Allen's test positive. Allen's test positive means you can poke radial artery. So write down the sequence of events. ABG sampling, ABG sampling, most commonly radial artery used. Most commonly radial artery used. We do modified Allen's test for patency of ulnar artery. So what are the sequence of it? On release of pressure, on release of pressure from ulnar artery, on release of pressure from ulnar artery. If hand turns pink, it means ulnar artery patent. It means ulnar artery patent. Ulnar artery patent means Allen's test positive. Allen's test positive means you can poke radial artery. You can poke radial artery. You can poke radial artery. So on release of pressure from ulnar artery and release of pressure from ulnar artery, if hand turns pink, ulnar artery patent, Allen's test positive, and you can poke the radial artery. And before taking the blood into syringe, something should be added into the syringe. What is that? Heparin. Because ABG mission cannot process clotted blood. So to prevent the blood clotting, we use heparin. Generally 0.1 to 0.2 ml heparin used. 0.1 to 0.2 ml heparin is used. ABG sampling, most commonly we are going to use radial artery. And modified Allen's test, on release of pressure from the ulnar artery, if a hand turns pink, it means ulnar artery is patent. If ulnar artery is patent, it means Allen's test is positive. Allen's test is positive, it means you can poke radial artery. If Allen's test is negative, you have to go for next hand, or you can go for femoral root. And before taking the blood into the syringe, there should be something added to this syringe. What is that? Heparin. How much heparin? 0.1 to 0.2 ml heparin can be used. So by this, we could conclude acid-base balance, starting from basic single respiratory disorders, mixed acid-base disorders. So apart from this, there is some extra edge in ABG, so which is of bit higher level. So once you understand the basic ABG, so you can also go through that. So that video also will be uploaded along with these videos in the next 1 or 2 days. So that is just an extra level for you, so that you will understand everything about ABG. So in that extra level, as of now, a question was not asked in your previous exam. Maybe it might be asked in future exam. So to make sure we have completed everything, so that is also being added shortly, so in 1 or 2 days. Now let us see some questions. You can see this is the modified Allen's test. Okay, you are blocking both arteries and releasing the pressure on ulnar artery. Once you release the pressure on ulnar artery, if the hand turns pink, ulnar patent means Allen's test positive. Allen's test positive means you can poke the radial artery. Now try to solve these questions. Yes. A 20-year-old anxious female with chronic hyperventilation. These are the ABG results. What is the abnormality? Whenever they give any ABG analysis, first you should see history-wise approach. History-wise approach. Now this patient is anxious and there is chronic hyperventilation. So history-wise, what can happen in this patient? Chronic respiratory alkalosis. Now ABG-wise. Yes, inappropriate compensation is mixed acid-base disorder according to 20th edition Harrison. So when the compensation is inappropriate, now we are using the terms mixed acid-base disorder. So partial compensation, decompensation, all these terms are not given in your 20th edition Harrison. So with clinical history, it should be called as mixed acid-base disorder. If they have not given any clinical history, you can use the old terms partial compensation, but that is not practiced nowadays. So ABG-wise diagnosis, pH increased, PaCO2 decreased, bicarbonate decreased. So going by the algorithm, I have seen the history. Now pH, it is alkalosis. The next step, what is the primary disorder? Change in pH with respect to parameter opposite. So it is respiratory alkalosis. So it is respiratory alkalosis. So Dr. Ali Ahmad, why it is metabolic alkalosis? So in metabolic alkalosis, what should happen to bicarbonate? It should increase. So this is a classical respiratory alkalosis. ABG wise, pH increase. So it is alkalosis. Change in pH with respect to parameter opposite. So it is respiratory alkalosis. A 60-year-old man with amyotrophic lateral sclerosis is brought into clinic by his family, who are concerned that he is more somnolent than normal. On further history, they report that he has been having problem with morning headaches and does not feel very refreshed when he wakes up. ABG analysis is performed here. What do you notice? Again, history-wise approach. History-wise approach. Amyotrophic lateral sclerosis, is a chronic neuromuscular disorder. So this patient will be having chronic respiratory acidosis. Now ABG wise approach. His pH reduced, PaCO2 increased, bicarbonate increased. Any decrease in pH is acidosis. Change in pH with respect to parameters, it is in opposite direction. So it is a primary respiratory acidosis. So steps in ABG. After clinical history, pH. Primary process. After primary process, compensatory response. So how to calculate compensation? This is a primary respiratory disorder. CO2 has increased from 40 to 60. It has increased by 20. So bicarbonate from normal value of 26, it should increase by 8. For 10 it is 4, for 20 it is 8. So it should reach to 34. So given is correlating with, given bicarbonate is correlating with expected bicarbonate. So given is 34, expected is also 34. So it is respiratory acidosis with compensatory metabolic alkalosis, or you can just write it as compensated respiratory acidosis. So it is not acute respiratory acidosis, because neuromuscular disorders, the history will be for months together. It will be for months together. Okay. So this is a chronic disease. So by history, amyotrophic lateral sclerosis is a chronic disease. Then a 6-year-old child is being evaluated for acidosis. So they have given so many values and they are asking you the blood anion gap, plasma anion gap. So when they ask you anion gap, whatever values they give in the question, you should only use these values to calculate. So how much is sodium? 140 minus chloride. So what is the chloride value? 112. How much is bicarbonate? 16. So 140 minus 128. So it is 12. So it is 12. So normal anion gap, metabolic acidosis. It is normal anion gap. So patient is having normal anion gap. So Yash Agarwal, compensation in which case? In previous case, in the sense this case. See, they have not asked in the question. So when they have not asked in the question, why you should go and see? See, whatever they have asked in the question, you don't have 10 to 15 minutes for every question. Okay, so they are only asking the primary process. Just to solve up to that enough. So if you want to calculate compensation, so this is a chronic hyperventilation. So for every 10 mm Hg decline in CO2, bicarbonate should also decline by 4. So it is roughly that. Okay. So roughly it will come about 20 only. So it is compensated. So in this is respiratory acidosis with compensated metabolic alkalosis. So in this case also, so CO2 has increased from 40 to 60. Now bicarbonate should increase from 26 to 34. So you know that formula, na? For every 10 mm Hg increase in CO2 in chronic respiratory acidosis, bicarbonate increases by 4. So this is 12. Okay. Normal anion gap. Now try to solve this question. Yes, first case only Yash Agarwal, it is compensated. If you calculate, see the formula for 10 mm Hg decline in CO2, 4 should be the decline in bicarbonate. So in the question, CO2 has declined to 20. So bicarbonate 25. So it has declined by 15. So bicarbonate should decline by 6. So from 26 it has to come to 20. It is also compensated. First question is compensated. But they have not asked that in the question. Whatever they ask in the question, till that you solve. No need to go for all the steps. Okay. It will be just waste of your time later on. 84-year-old female, diarrhea. So these were the parameters given, electrolytes given, ABG given. What is the acid-base disorder? So this is the last case of the day. So apply all the steps. You will get the answer. History-wise approach. Patient is having diarrhea. What can diarrhea cause? Diarrhea can cause normal anion gap metabolic acidosis. ABG wise approach. pH 7.29, PaCO2 24, bicarbonate 10. Decline. So decrease in pH, acidosis. That step is over. Next, what is primary? Same direction. So the name should be metabolic. So compensation. So this is a primary respiratory disorder. How will you calculate compensation? Expected CO2 1.5 into bicarbonate is 10 plus 8 plus or minus 2. So the CO2 will be, if you calculate with this, 21 to 21 mm Hg. So this is, how much is given? 24. So given CO2 24 is correlating with expected CO2. So this is metabolic acidosis with compensatory respiratory alkalosis. After compensation, what is the next step? Calculation of anion gap. So how much is sodium? 137 minus, how much is chloride? 117 plus bicarbonate 10. 137 minus 127. So it is 10. So it is a normal anion gap metabolic acidosis with compensatory respiratory alkalosis. So the best answer is option C. Non-anion gap means no high anion gap metabolic acidosis. It means normal anion gap metabolic acidosis. Now if you see in this question, we have followed all these steps. So clinical history, what is the ABG? Is it acidosis or alkalosis? What is the primary process? Compensatory response, and finally anion gap. So this is how you should approach to ABG. So by this we have concluded our sessions on respiratory medicine and acid-base balance. So like I promised you, so I'll give you a special video on lung cancer staging. So it is about 1 to 1.5 hours, because lung cancer staging is the most difficult staging of all cancers, because you should know the mediastinal lymph node anatomy. So I have given a detailed description. So it was not asked in the exam. So but it is better to, if at all you are interested further to learn about lung cancer staging, it will be helpful. And also I am incorporating some extra edge in ABG. So the delta anion gap concepts, urinary anion gap concepts, base deficits, validity of ABG. So which are very rarely asked, but for completion's sake, you can have a good look into it. And next important thing is, we have discussed some 30 clinical questions in respiratory medicine. So that 30 clinical questions PDF will also be uploaded. So it was a great pleasure being with you, and I hope I have made you learn some important aspects in respiratory medicine. So before concluding, so whenever I conclude my class, after the class, actually when there was a face-to-face class, so students used to come and ask me the same question: sir, why is it so important to get into post-graduation degree? So especially male medicos. So this is the only advice that I give to male medicos. See, MBBS degree will give you pride, but it is PG degree only that gets you good bride. So if you want to get married and settle down early, and if you want to be lucky to find a good bride, so it is only PG degree. So that is the only way. So thank you so much, students. I'll be here for another 5 to 10 minutes. I'll be taking your doubts. So any doubts, you can mail me. This is my mail ID, and you can also tag me in DAMS Exclusive Club. You can type your doubts, students. By the way, everybody, I wish you very happy new year. Hope we will overcome this COVID very soon in the first quarter of the year, and all our routine work should come back as normal it was previously. Okay, students, everybody stay safe, take care, and wishing you bright future.